Reproductive audiobook for USMLE Step 1. Let's see the journey of early embryonic development, beginning with ovulation in the ovary, where a secondary oocyte, which is 1N2C, is released. After fertilization occurs in the fallopian tube, the zygote forms, holding a 2N4C state, meaning it has 2 sets of chromosomes and 4 sets of chromatids or DNA copies. This marks day 0, and as the fertilized egg travels through the fallopian tube, it progresses through several stages, reaching the zygote stage on day 1. Are you following me? By days 2 to 3, the fertilized cell undergoes cleavage, producing smaller cells while maintaining its size. Then, by day 4, these cells compact into a morula. As development continues, a fluid-filled cavity forms inside the morula, transforming it into a blastocyst by day 5. This blastocyst is now ready for implantation, which takes place between days 6 and 10, and the site of implantation is the endometrium of the uterus. Alongside this, other supporting structures form, such as the early corpus luteum and the corpus albicans, while the myometrium continues to support the uterine wall. Now let's talk about the next phase, which happens around days 14 to 16. After implantation, a bilaminar disc develops, composed of 2 layers called the epiblast and the hypoblast. The blastocyst cavity now contains amniotic fluid and a yolk sac. Then, by day 15, a structure known as the primitive streak forms on the epiblast, marking the beginning of gastrulation. During this process, epiblast cells move through the primitive streak to create a trilaminar structure, giving rise to the 3 germ layers, ectoderm, mesoderm, and endoderm. By day 16, these layers are clearly formed and are essential for building all future tissues and organs. Are you following me? In week 1, secretion of HCG begins, which typically coincides with blastocyst implantation. A helpful mnemonic is that the blastocyst sticks on day 6. Moving into week 2, the bilaminar embryonic disc forms, and as mentioned earlier, it comprises 2 layers, epiblast and hypoblast. By week 3, the trilaminar disc is established through gastrulation, where epiblast cells migrate through the primitive streak to form the 3 primary germ layers, endoderm, mesoderm, and ectoderm. During this same time, the notochord arises from the midline mesoderm and signals the overlying ectoderm, using sonic hedgehog or SH, to become the neural plate, which then folds into the neural tube through neurulation. Now let's talk about week 4, when the heart begins to beat and forms 4 chambers. Cardiac activity becomes visible through transvaginal ultrasound at this stage. Also during this week, both upper and lower limb buds begin to form, giving rise to the 4 limbs. Finally, by week 8, the genitalia begin to develop male or female characteristics, and here's a fun memory trick: you can pronounce it genitalia to remember this important milestone. Now let's talk about the embryologic derivatives, beginning with the ectoderm, mesoderm, and endoderm, which are the 3 germ layers formed during gastrulation. On day 16, these layers are established, and each one begins to give rise to specific tissues and structures. From the ectoderm, by day 19, a neural groove begins to form, followed closely by the appearance of the neural crest and the notochord. As we move to day 20, the neural fold becomes more pronounced, and the neural crest continues its development. Then, by day 22, the neural tube is formed, completing the primary structure that will give rise to the central nervous system. Now listen carefully, the ectoderm is known as the external or outer layer. From the surface ectoderm, various important structures develop, including the epidermis, the adenohypophysis which forms from Rathke's pouch, the lens of the eye, and the epithelial linings of the oral cavity. It also forms sensory organs of the ear and the olfactory epithelium, the anal canal below the pectinate line, as well as the parotid, sweat, and mammary glands. You should remember that a craniopharyngioma is a benign tumor of Rathke's pouch, often containing cholesterol crystals and calcification. The neural tube, which originates from the ectoderm as well, gives rise to the brain, including the neurohypophysis, CNS neurons, oligodendrocytes, astrocytes, and ependymal cells. It also forms the pineal gland, retina, and spinal cord. Neuroectoderm is mainly associated with CNS structures. Are you following me? The neural crest, which also derives from the ectoderm, gives rise to many critical components, including enterochromaffin cells, melanocytes, and odontoblasts. It also forms the ganglia of the peripheral nervous system such as cranial, dorsal root, and autonomic ganglia. In addition, it contributes to the adrenal medulla, Schwann cells, and the spiral membrane or aorticopulmonary septum, as well as the endocardial cushions which are also partially derived from mesoderm, and the bones of the skull. A helpful mnemonic is EMO passes, reminding you of the neural crest's contributions to PNS and several non-neural nearby structures. Now let's talk about the mesoderm, which is the middle or meat layer. It forms muscle, bone, connective tissue, and the serous linings of body cavities such as the peritoneum, pericardium, and pleura. The spleen also develops within the foregut mesentery, and the mesoderm gives rise to cardiovascular structures, lymphatics, and blood. It contributes to the wall of the gut tube, the proximal vagina, the kidneys, the adrenal cortex, the dermis, the testes, the ovaries, the microglia, and tracheal cartilage. Importantly, the notochord, which arises from the mesoderm, induces the overlying ectoderm to form the neuroectoderm or neural plate, and its only postnatal remnant is the nucleus pulposus of the intervertebral disc. You should remember this. Mesodermal defects are often grouped under the VACTERL association, which includes vertebral defects, anal atresia, cardiac defects, tracheoesophageal fistula, renal defects, and limb defects involving bone and muscle. And finally, now listen carefully to the endoderm, which is sometimes referred to as the internal layer. It forms the gut tube epithelium, including the anal canal above the pectinate line, and also most of the urethra and the distal vagina, which are derived from the urogenital sinus. Furthermore, it gives rise to luminal epithelial derivatives such as the lungs, liver, gallbladder, pancreas, eustachian tube, thymus, parathyroid, and both follicular and parafollicular or C cells of the thyroid. Teratogens exert their most severe effects during organogenesis in the embryonic period, which occurs before week 8 of development. During this time, the fetus is especially susceptible to structural abnormalities. Before implantation, exposure to teratogens leads to an all-or-none effect, meaning the embryo either survives without harm or is lost entirely. However, after week 8, during the fetal period, teratogens primarily affect the growth and function of organs rather than their structure, and understanding the timing of exposure is crucial when assessing the risk of congenital anomalies. Several medications are well-known teratogens. ACE inhibitors can lead to renal failure, oligohydramnios, and hypocalvaria. Alkylating agents may cause multiple anomalies, such as ear and facial abnormalities and the absence of digits. Aminoglycosides are associated with ototoxicity, and you might remember this with the phrase, "a mean guy hit the baby in the ear." Antiepileptic drugs are linked to neural tube defects, cardiac defects, cleft palate, and skeletal abnormalities like phalanx or nail hypoplasia and facial dysmorphism, most commonly due to valproate, carbamazepine, phenytoin, or phenobarbital, and high-dose folate supplementation is strongly recommended during their use. Now let's talk about other medications with serious teratogenic effects. Diethylstilbestrol can cause vaginal clear cell adenocarcinoma and congenital Müllerian anomalies. Fluoroquinolones are known to damage cartilage. Folate antagonists, including trimethoprim and methotrexate, commonly cause neural tube defects. Isotretinoin leads to craniofacial abnormalities such as microtia and dysmorphism, as well as CNS, cardiac, and thymic defects, and because of its potency, contraception is mandatory. For better recall, think of pronouncing it isoteratinoin. Lithium has been linked to abstain anomaly. Methimazole may cause aplasia cutis congenita, which is the congenital absence of skin, typically on the scalp. Tetracyclines result in discolored teeth and inhibited bone growth, hence the nickname tetracyclines. You should remember this. Thalidomide causes limb defects, such as phocomelia or flipper-like limbs, and you might pronounce it thalidomide to recall this effect. Warfarin, another serious teratogen, can lead to bone and cartilage deformities like stippled epiphyses, nasal and limb hypoplasia, optic nerve atrophy, and even cerebral hemorrhage. It's important to use heparin during pregnancy instead, since it does not cross the placenta. You can remember warfarin's effects by thinking, in war, you need strong bones to march and optics to see the enemy. Now let's shift to substance use. Alcohol exposure in utero results in fetal alcohol syndrome. Cocaine use is linked to preterm birth, low birth weight, and fetal growth restriction because it increases vasoconstriction. Tobacco smoking contributes to preterm birth, low birth weight, which is the leading cause in resource-rich countries, fetal growth restriction, sudden infant death syndrome or SIDS, and ADHD. Nicotine increases vasoconstriction, and carbon monoxide impairs oxygen delivery, both of which contribute to these harmful effects on fetal development. And finally, let's cover a few other important teratogenic factors. Iodine, whether lacking or in excess, can result in congenital hypothyroidism. Maternal diabetes is associated with caudal regression syndrome, cardiac defects like transposition of the great arteries and ventricular septal defects, neural tube defects, macrosomia, neonatal hypoglycemia due to islet cell hyperplasia, polycythemia, and respiratory distress syndrome. Maternal phenylketonuria, or PKU, leads to fetal growth restriction, microcephaly, intellectual disability, and congenital heart defects. Methylmercury causes neurotoxicity, and it accumulates in top predator fish such as shark, swordfish, king mackerel, and tilefish. Exposure to X-rays may result in microcephaly and intellectual disability, but these effects can be minimized with proper use of lead shielding. Now let's talk about the different types of errors that can occur in morphogenesis. Agenesis refers to an absent organ due to the complete absence of primordial tissue. Aplasia means the organ is absent even though the primordial tissue is present. Hypoplasia involves incomplete organ development, where the primordial tissue exists but does not develop fully. Disruption is a secondary breakdown of tissue that initially had normal developmental potential, for example, amniotic band syndrome. Deformation results from extrinsic mechanical distortion, such as congenital torticollis, and this usually happens during the fetal period. Malformation, on the other hand, is an intrinsic developmental defect, like cleft lip or palate, and it typically arises during the embryonic period. Sequence refers to a series of abnormalities that stem from a single primary embryologic event, like oligohydramnios leading to Potter sequence. Lastly, a field defect is a disturbance in the development of tissues that are located within a contiguous physical area, such as in holoprosencephaly. Now listen carefully. Fetal alcohol syndrome is one of the leading preventable causes of intellectual disability in the United States. It occurs secondary to maternal alcohol consumption during pregnancy. Newborns affected by this condition may exhibit developmental delay and microcephaly, along with facial abnormalities such as a smooth philtrum, a thin vermilion border, small palpebral fissures, and a flat nasal bridge. They may also have limb dislocation and heart defects. In more severe presentations, holoprosencephaly may develop. One mechanism behind these effects involves impaired migration of neuronal and glial cells. Treatment is centered around supportive care to help manage the symptoms and improve the child's development and quality of life over time. So you should know that microcephaly, flat nasal bridge, small palpebral fissures, a thin vermilion border, and a smooth philtrum. These facial features often help in identifying underlying syndromes like fetal alcohol syndrome. Now moving on to neonatal abstinence syndrome, this is a complex disorder that affects the central nervous system, autonomic nervous system, and gastrointestinal system. It results from maternal substance use during pregnancy, most commonly opioids. Affected newborns may display uncoordinated sucking reflexes, irritability, high-pitched crying, tremors, tachypnea, sneezing, diarrhea, and in some cases, seizures. Now let's shift our focus to treatment, especially for opioid use. Neonatal abstinence syndrome is typically managed with medications like methadone, morphine, or buprenorphine. And it's important to note that universal screening for substance use is recommended in all pregnant patients to identify and mitigate such risks early on. Now let's talk about the placenta, which is the primary site for nutrient and gas exchange between the mother and the fetus. On the fetal side, the cytotrophoblast forms the inner layer of the chorionic villi and is responsible for creating cells. The syncytiotrophoblast, which is the outer layer of the chorionic villi, synthesizes and secretes hormones like hCG. This hormone is structurally similar to LH and stimulates the corpus luteum to secrete progesterone during the first trimester. Interestingly, the syncytiotrophoblast lacks MHC class I expression, which helps reduce the chance of maternal immune attack. Now listen carefully. On the maternal side, the decidua basalis is derived from the endometrium, and maternal blood fills the lacunae within it. Let's now talk about amniotic fluid, which plays a crucial role in fetal development. It is mainly derived from fetal urine and fetal lung liquid. The fluid is cleared primarily through fetal swallowing and also through intramembranous absorption. Polyhydramnios refers to having too much amniotic fluid. This condition may be idiopathic, but it's also associated with fetal malformations such as esophageal or duodenal atresia and anencephaly, both of which result in the inability of the fetus to swallow amniotic fluid. It can also be linked to maternal diabetes, fetal anemia, and multifetal gestation. And finally, oligohydramnios means there is too little amniotic fluid. This condition is associated with placental insufficiency, bilateral renal agenesis, and posterior urethral valves, particularly in males. These issues impair the fetus's ability to excrete urine, which reduces the volume of amniotic fluid. Profound oligohydramnios can lead to Potter sequence, a serious complication characterized by pulmonary hypoplasia, limb deformities, and facial anomalies, all of which stem from compression and restricted movement in utero. Twinning can occur in two main ways. Dizygotic, or fraternal, twins arise from two separate eggs, each fertilized by a different sperm, meaning there are always two zygotes. These twins will have two separate amniotic sacs and two separate placentas, or chorions. In contrast, monozygotic, or identical, twins arise from a single fertilized egg, one egg and one sperm, that splits during early pregnancy. The timing of this splitting determines whether the twins share chorions or amnions, or even parts of the body. If splitting occurs between 0 and 4 days, there is a separate chorion and amnion, referred to as DD. If it happens between 4 and 8 days, the twins share a chorion but have separate amnions, making it MOD. If the split occurs between 8 and 12 days, both the chorion and the amnion are shared, which is MOMO. And if the split takes place after 13 days, the twins share the chorion, the amnion, and also parts of the body, resulting in conjoined twins, which are also classified as MOMO. Now listen carefully, compares the development of dizygotic and monozygotic twins, showing how different types of twin pregnancies arise depending on when the embryo splits. In case of fraternal twins, which account for about 2/3 of all twin births, they result from two separate eggs fertilized by two separate sperm. Each develops into a morula and then into a blastocyst on its own. They each form their own embryonic disc, and since they have separate placentas and amniotic sacs, they are called dichorionic diamniotic. This type always involves separate chorions and amnions. Now let's talk about monozygotic, or identical twins, which represent about 1/3 of all twin births. These twins come from a single egg fertilized by a single sperm, and the outcome depends on when the embryo splits. If the split happens early, between days 0 and 4, the two embryos will each form separate blastocysts. This results in dichorionic diamniotic twins, which is about 25% of monozygotic cases, and they have separate placentas and sacs, just like fraternal twins, but they are genetically identical. Are you following me? When splitting occurs between days 4 and 8, after the morula stage but before the blastocyst is fully formed, the result is typically monochorionic diamniotic twins. This is the most common scenario, making up around 75% of monozygotic twins. In this case, both embryos share one chorion but have separate amniotic sacs, meaning one placenta but two sacs. Now listen carefully, if the embryo splits between days 8 and 12, after the amniotic cavity has already begun forming, then the twins will share both the chorion and the amniotic sac. This is called monochorionic monoamniotic, and it's rare. This situation carries higher risks during pregnancy because the twins are in the same sac without a separating membrane. And finally, if splitting occurs on day 13 or later, or if there's axis duplication instead of full separation, the result is conjoined twins, which is a very rare outcome. These twins are also monochorionic monoamniotic, but they remain physically connected because the separation was incomplete. Twin-twin transfusion syndrome occurs in monochorionic twin pregnancies. In this condition, unbalanced arteriovenous anastomoses form between the twins within their shared placenta, leading to a net blood flow from one twin to the other. The donor twin then becomes hypovolemic and develops oligohydramnios, giving a stuck twin appearance. On the other hand, the recipient twin experiences hypervolemia and develops polyhydramnios. Now let's talk about the umbilical cord. It typically contains two umbilical arteries, which return deoxygenated blood from the fetal internal iliac arteries to the placenta, and one umbilical vein, which supplies oxygenated blood from the placenta to the fetus. This vein drains either into the inferior vena cava through the liver or via the ductus venosus. If there is only a single umbilical artery, also known as a two-vessel cord, it may be associated with congenital or chromosomal anomalies. The umbilical arteries and the vein are both derived from the allantois, and they are surrounded by protective Wharton jelly within the amnion. Now listen carefully, the allantois is a structure that forms from the yolk sac and extends into the cloaca. Its intra-abdominal remnant is called the urachus, which acts as a duct between the fetal bladder and the umbilicus. If the urachus fails to involute properly, it can lead to anomalies that increase the risk of infection or even malignancy, such as adenocarcinoma, if left untreated. After birth, the obliterated urachus becomes the median umbilical ligament, which is covered by the median umbilical fold of the peritoneum. If there is a total failure of the urachus to obliterate, it results in a patent urachus, where urine discharges from the umbilicus. Now let's talk about urachal anomalies. A urachal cyst forms when there is partial failure of the urachus to obliterate. This results in a fluid-filled cavity lined with uroepithelium that lies between the umbilicus and the bladder. This cyst can become infected and may present as a painful mass just below the umbilicus. Another anomaly is the vesicourachal diverticulum, which occurs when the urachus fails slightly to obliterate, leading to an outpouching from the bladder. These conditions require monitoring and, if needed, treatment to avoid complications. Now listen carefully, the vitelline duct, also known as the omphallomesenteric duct, connects the yolk sac to the midgut lumen during early development and usually obliterates by the 7th week. If this duct fails to obliterate completely, it can cause several abnormalities. A patent vitelline duct, which is the result of total failure, leads to meconium discharge from the umbilicus. A vitelline duct cyst occurs with partial failure, increasing the risk for volvulus. And mechal diverticulum results from a slight failure to obliterate, forming an outpouching of the ileum, known as a true diverticulum. Although often asymptomatic, mechal diverticulum may contain heterotopic gastric or pancreatic tissue and can cause melena, hematochezia, or abdominal pain. Now let's talk about the pharyngeal apparatus, which is composed of pharyngeal clefts, arches, and pouches. Pharyngeal clefts are derived from ectoderm and are also called pharyngeal grooves. Meanwhile, pharyngeal arches are derived from mesoderm, which contributes to muscles and arteries, and from neural crest, which gives rise to bones and cartilage. On the other hand, pharyngeal pouches are derived from endoderm. And to help you remember the layers from outside to inside, just think of CAP, where clefts come from ectoderm, arches arise from mesoderm and neural crest, and pouches develop from endoderm. So now, regarding the derivatives of the pharyngeal clefts, the first cleft develops into the external auditory meatus. While the second through fourth clefts form temporary cervical sinuses, these are later obliterated by the proliferation of the second arch mesenchyme. But if a cervical sinus persists, it results in a pharyngeal cleft cyst, which presents as a lateral neck mass located anterior to the sternocleidomastoid muscle. Importantly, this mass does not move with swallowing, which distinguishes it from a thyroglossal duct cyst. Moving inward, the pharyngeal pouches give rise to structures from the ear down to the parathyroid glands. Starting from the bottom and going to the top, the first pouch forms the middle ear cavity, the eustachian tube, and the mastoid air cells. First pouch contributes to endoderm-line structures of ear. The second pouch forms the epithelial lining of the palatine tonsil. Next, the third pouch divides into dorsal wings, which become the inferior parathyroids, and ventral wings, which become the thymus. Interestingly, structures from the third pouch end up located below those derived from the fourth pouch. Third pouch contributes to thymus, and both inferior parathyroid structures from third pouch end up below those from fourth pouch. Speaking of which, the fourth pouch's dorsal wings form the superior parathyroids, and the ventral wings develop into the ultimopharyngeal body, which contributes parafollicular or C cells to the thyroid. Now listen carefully. Developmental anomalies in the third and fourth pharyngeal pouches are associated with DiGeorge syndrome. And you should remember that sensory and motor nerves are not derivatives of the pharyngeal arches themselves. Instead, they grow into the arches and originate from neural crest for sensory components and neuroectoderm for motor components. Additionally, arches 3 and 4 contribute to the formation of the posterior one-third of the tongue, while the fifth arch makes no significant developmental contributions. Are you following me? Here's a helpful way to recall the cranial nerve associations and their functions within the arches. When at the restaurant of the golden arches, children tend to first chew with arch 1, then smile with arch 2, then swallow stylishly with arch 3, simply swallow with arch 4, and finally speak with arch 6. Now let's break that down. The first pharyngeal arch is associated with CNV3 and is involved in chewing. It gives rise to the muscles of mastication like temporalis, masseter, lateral and medial pterygoids, along with mylohyoid, anterior belly of digastric, tensor tympani, the anterior two-thirds of the tongue, and tensor veli palatini. In terms of cartilage, the first arch gives rise to the maxillary process, which forms the maxilla and zygomatic bone, and the mandibular process, which includes mechal cartilage, forming the mandible, malleus and incus, and the sphenomandibular ligament. Meanwhile, the second pharyngeal arch is innervated by cranial nerve 7 and is responsible for smiling. It forms muscles of facial expression, stapedius, stylohyoid, platysma, and the posterior belly of the digastric. Its cartilage, Reichert cartilage, forms the stapes, styloid process, lesser horn of the hyoid, and the stylohyoid ligament. Now let's move on to the third arch, which is innervated by cranial nerve 9 and allows you to swallow stylishly. It forms the stylopharyngeus muscle and contributes the greater horn of the hyoid bone. And finally, arches 4 and 6 are both innervated by branches of cranial nerve 10. The fourth arch, through the superior laryngeal branch, helps you simply swallow and forms most of the pharyngeal constrictors, cricothyroid, and levator veli palatini. The sixth arch, via the recurrent laryngeal branch, helps you speak and gives rise to all the intrinsic muscles of the larynx except cricothyroid. Cartilage derivatives from these arches include the arytenoids, cricoid, corniculate, cuneiform, and thyroid cartilages, all of which are used to sing and can be remembered using ACCCT. Now listen carefully to some clinical implications. First and second pharyngeal arch syndromes include Pierre-Robin sequence and Treacher-Collins syndrome. Pierre-Robin sequence involves mandibular hypoplasia or micrognathia, which causes posteriorly displaced tongue or glossoptosis, leading to cleft palate and airway compromise, with feeding difficulties being common. Treacher-Collins syndrome, which is autosomal dominant, involves neural crest dysfunction and results in craniofacial abnormalities such as zygomatic bone and mandibular hypoplasia, along with hearing loss and airway compromise. Now listen carefully. Orofacial clefts such as cleft lip and cleft palate have distinct, multifactorial etiologies, but they often occur together. Cleft lip is due to failure of fusion of the intermaxillary segment, which is formed by the merged medial nasal processes, with the maxillary process, and this contributes to the formation of the primary palate. The frontonasal process gives rise to the medial nasal process and lateral nasal process, which eventually contribute to the intermaxillary segment and the formation of the primary palate. The maxillary process contributes to the lateral parts of the upper lip, and when fusion fails, a cleft lip results. Now let's talk about cleft palate, which is due to failure of fusion of the two lateral palatine shelves, or failure of fusion of the lateral palatine shelf with the nasal septum and/or with the primary palate, and this leads to defective formation of the secondary palate. The palatine shelves, which develop laterally, must meet in the midline and also fuse with the primary palate and nasal septum, and when this fails, a cleft palate is the result. The uvula may also be affected, and these defects can severely impair feeding and speech unless surgically corrected. Now moving to genital embryology, in the female, default development occurs, where the mesonephric duct degenerates and the paramesonephric duct develops. The paramesonephric duct goes on to form the fallopian tubes, uterus, and the proximal part of the vagina, while the distal vagina is derived from the urogenital sinus. The absence of androgens and Müllerian inhibiting factor allows this pathway to proceed, and in this scenario, the mesonephric duct regresses. Now listen carefully, in the male, the SRY gene on the Y chromosome produces the testis-determining factor, which promotes development of the testes. Sertoli cells then secrete Müllerian inhibiting substance, also called anti-Müllerian hormone, which suppresses the development of the paramesonephric ducts. At the same time, Leydig cells secrete androgens, which stimulate development of the mesonephric ducts into male internal structures. Now let's go deeper. The paramesonephric or Müllerian duct develops into female internal structures, such as the fallopian tubes, the uterus, and the proximal vagina, and in males, a remnant of this duct may persist as the appendix testis. In a condition called Müllerian agenesis, or Mayer-Rokitansky-Kusterhauser syndrome, primary amenorrhea occurs due to an absent uterus and a blind vaginal pouch, while external genitalia are normal and secondary sexual characteristics are present due to functional ovaries. This syndrome is also associated with urinary tract anomalies like renal agenesis. Finally, the mesonephric or Wolffian duct develops into male internal structures, excluding the prostate, and these include the seminal vesicles, the epididymis, the ejaculatory duct, and the ductus deferens, forming the seed components. In females, a remnant of the mesonephric duct may persist as the Gartner duct. Are you ready to dive into the process of sexual differentiation? Let's start with the basics. In early development, the gonads are undifferentiated, and the presence or absence of the SRY gene determines the direction. If the embryo has XY chromosomes, the SRY gene becomes active and leads to the development of testes, while if the embryo is XX and lacks the SRY gene, ovaries develop instead. From here, the path of differentiation diverges between male and female. Now listen carefully. In individuals with XY chromosomes, the testes produce two key hormones. Sertoli cells release Müllerian inhibiting substance, also called MIS, which causes regression of the paramesonephric or Müllerian ducts, preventing female internal structures from forming. Meanwhile, Leydig cells produce testosterone, which promotes development of the mesonephric or Wolffian duct into internal male genitalia including the seminal vesicle, epididymis, ejaculatory duct, and ductus deferens. Some of this testosterone is converted by the enzyme 5-alpha reductase into dihydrotestosterone, or DHT. Now let's talk about what DHT does. DHT drives the formation of external male genitalia, including the penis, scrotum, and prostate. Later on, during puberty, testosterone also contributes to secondary sexual characteristics, like the growth of pubic, axillary, and facial hair, increased penis size and length, and the adolescent growth spurt. Switching over to the female pathway, when there is no SRY gene, the gonads become ovaries. These ovaries do not secrete MIS, so the paramesonephric ducts persist and develop into the fallopian tubes, uterus, and proximal part of the vagina. Since there are no high levels of testosterone, the mesonephric ducts regress, and the external genitalia develop into the clitoris, labia, and distal vagina. Now listen carefully again. Estrogen plays a central role in female differentiation. It promotes the development of external female genitalia, and at puberty, it stimulates breast development along with other secondary sexual characteristics like the growth of pubic and axillary hair. So as mentioned earlier in XY individuals, when Sertoli cells are absent, or when there is a lack of Müllerian-inhibiting substance, both male and female internal genitalia can develop. However, male external genitalia still form, and the gonads appear as streak gonads. Now listen carefully. In cases of 5-alpha reductase deficiency, there is an inability to convert testosterone into dihydrotestosterone. This results in the development of male internal genitalia, but the external genitalia remain atypical until puberty, when the rise in testosterone levels leads to masculinization. Now let's talk about the role of testicular cells in sexual differentiation. In the testes, Leydig cells are responsible for initiating male sexual differentiation, both internal and external. On the other hand, Sertoli cells function to shut down female internal sexual differentiation, and they do this by secreting Müllerian-inhibiting substance, which causes regression of the paramesonephric ducts. So, while Leydig cells promote male features, Sertoli cells suppress female structures. Moving forward, let's discuss uterine or Müllerian duct anomalies. These anomalies are associated with reduced fertility and an increased risk of complicated pregnancy. Such complications may include spontaneous abortion, prematurity, fetal growth restriction, and malpresentation. When examining the uterus with a hysterosalpingogram, a normal uterus shows a well-formed cavity and free intraperitoneal spill of contrast, which suggests that the fallopian tubes are patent and open. Now listen carefully again. One common anomaly is a septate uterus, which results from incomplete resorption of the septum. This is the most frequent type of uterine anomaly and is typically treated with a surgical procedure called septoplasty. Another anomaly is a bicornuate uterus, which arises due to incomplete fusion of the Müllerian ducts. This creates a uterus with two horns, which may increase the risk of adverse pregnancy outcomes. Lastly, in some rare cases, there can be a complete failure of fusion of the Müllerian ducts. This leads to a condition known as uterus didelphys, where a woman has a double uterus, double cervix, and sometimes even a double vagina. Now let's talk about male and female genital homologs. Both develop from a common embryologic origin, but under the influence of different hormones, they take on male or female forms. In the male, the kidney develops alongside the testis and ureter, while in the female, it develops with the ovary and ureter. Now listen carefully. The glans penis in the male and the glans clitoris in the female both derive from the genital tubercle. The spongy urethra in males corresponds to the vestibular bulbs in females, while the corpus cavernosum and spongiosum in males are homologous to the erectile tissue in the female genitalia. Are you following me so far? The urogenital sinus gives rise to the greater vestibular glands, also called Bartholin glands, in females and to the bulbourethral glands, or Cooper glands, in males. Furthermore, the same sinus gives rise to the urethral and periurethral glands of Skene in females, which correspond to the prostate gland in males. The urogenital folds form the labia minora in females and the ventral shaft of the penis, including the penile urethra, in males. Labioscrotal swelling becomes the labia majora in females, while in males it fuses to form the scrotum. Now listen carefully. These embryologic structures can also lead to abnormalities. In congenital penile abnormalities, hypospadias is an abnormal opening of the penile urethra on the ventral, or underside, surface. This condition is due to failure of the urethral folds to fuse. Hypospadias is more common than epispadias and is often associated with inguinal hernia, cryptorchidism, and chordee, which is a downward or upward bending of the penis. It can also be seen in 5-alpha reductase deficiency, a condition that affects DHT production. Are you ready to hear the other abnormality? Epispadias, on the other hand, is an abnormal opening of the penile urethra on the dorsal, or top, surface. This results from faulty positioning of the genital tubercle. Exstrophy of the bladder, which is the protrusion of the bladder through the abdominal wall, is associated with epispadias. Now let's talk about the descent of the testes and ovaries. The gubernaculum is a band of fibrous tissue, and in males, it anchors the testes within the scrotum. In females, this same structure persists as the ovarian ligament and the round ligament of the uterus. Meanwhile, the processus vaginalis is an evagination of the peritoneum. In males, it forms the tunica vaginalis, but if it remains patent, it can lead to a condition called hydrocele. However, in females, it becomes obliterated during development. Now listen carefully as we move on to the drainage of reproductive organs. The venous drainage in the male and female bodies follows different paths. The right ovary or testis drains into the right gonadal vein, which then flows directly into the inferior vena cava. On the other hand, the left ovary or testis drains into the left gonadal vein, which empties into the left renal vein before reaching the IVC. Because the left testicular vein enters the left renal vein at a 90-degree angle, the flow becomes less laminar compared to the right side. This anatomical difference causes left venous pressure to be higher than the right, and as a result, varicocele is more common on the left side. Are you ready to hear about lymphatic drainage? The lymphatic drainage of reproductive organs also varies by location. The glans clitoris and the glans penis both drain into the deep inguinal lymph nodes. Structures like the distal vagina, vulva, and scrotum drain into the superficial inguinal lymph nodes. Meanwhile, the inferior part of the bladder, the cervix, the proximal vagina, the prostate, and the corpus cavernosum drain into the internal iliac lymph nodes. But there's more. Now let's shift to the external iliac drainage. The superior part of the bladder, the body of the uterus, and the cervix drain into the external iliac lymph nodes. The ovaries, fallopian tubes, and uterine fundus, along with the testes, drain into the paraortic lymph nodes, which are located higher in the abdomen. Let's explore the anatomy of female reproductive ligaments and their clinical significance. The infundibulopelvic ligament connects the ovary to the lateral pelvic wall, and it contains the ovarian vessels. It is also called the suspensory ligament of the ovary. During an oophorectomy, ligating the ovarian vessels in this ligament carries a risk of damaging the ureter. Then there's the utero-ovarian ligament, which links the ovary to the uterine horn, and it is a derivative of the gubernaculum. Another important structure is the round ligament, which runs from the uterine horn to the labia majora, traveling through the inguinal canal, and like the utero-ovarian ligament, it is also derived from the gubernaculum. Now listen carefully as we shift to the broad ligament, which stretches from the uterus to the lateral pelvic wall. It contains the ovary, fallopian tube, and round ligament, and it is a fold of peritoneum that includes the mesometrium, mesovarium, and mesosalpinx. The cardinal ligament, which runs from the cervix to the lateral pelvic wall, carries the uterine vessels and is a condensation at the base of the broad ligament. During a hysterectomy, ligation of these uterine vessels risks injury to the ureter. Another key structure is the uterosacral ligament, which connects the cervix to the sacrum and provides important support to the uterus. Now let's talk about adnexal torsion, which is a twisting of the ovary and fallopian tube around the infundibulopelvic ligament and the ovarian ligament. This twisting compresses the ovarian vessels within the infundibulopelvic ligament, blocking lymphatic and venous outflow. However, arterial perfusion may continue, leading to ovarian edema. If arterial inflow also becomes completely blocked, necrosis and local hemorrhage can occur. This condition is often associated with ovarian masses or cysts and presents with acute pelvic pain, an adnexal mass, and symptoms like nausea or vomiting. It is considered a surgical emergency and requires prompt attention. Now let's move on to pelvic organ prolapse, which is the herniation of pelvic organs to or beyond the vaginal walls, including anterior, posterior, or apical compartments. It is commonly associated with multiparity, increased age, and obesity. The clinical presentation includes pelvic pressure, a bulging sensation, or visible tissue protruding from the vagina, along with urinary frequency, constipation, or sexual dysfunction. The anterior compartment prolapse most commonly involves the bladder and is known as a cystocele. The posterior compartment prolapse may involve the rectum, called a rectocele, or the small bowel, referred to as an enterocele. Lastly, the apical compartment prolapse involves the uterus, cervix, or the vaginal vault. And finally, you should remember uterine precedentia, which is a severe form of prolapse involving all three compartments at once. The female reproductive epithelial histology. The vulva is made of stratified squamous epithelium, while the vagina is also lined by stratified squamous epithelium that is non-keratinized. The ectocervix shares this same non-keratinized stratified squamous epithelium. Moving inward, the transformation zone is the squamocolumnar junction, and this is the most common area for cervical cancer, and it is the region sampled in a Pap test. The endocervix, on the other hand, is lined by simple columnar epithelium. The uterus has simple columnar epithelium as well, but with long tubular glands in the proliferative phase and coiled glands in the secretory phase. The fallopian tube contains simple columnar epithelium that is ciliated. Finally, the outer surface of the ovary is lined by simple cuboidal epithelium, known as the germinal epithelium, which covers the surface of the ovary. Now let's talk about the male reproductive system in a simplified and engaging way. The sperm's journey can be remembered as a 7-up trip during ejaculation. First, sperm begins in the seminiferous tubules, which act as sperm factories located in the testicles. Then it travels to the epididymis, the sperm maturation warehouse. From there, it moves through the vas deferens, which is the sperm transportation highway. After that, it enters the ejaculatory duct, which serves as the semen mixing zone. The next step, humorously, is nothing, just a placeholder in the mnemonic. Then comes the urethra, which acts as the final exit tunnel. Finally, sperm is delivered through the penis, which is the external delivery system. Now let's break down the key parts and their jobs. The testicles, or testes, contain seminiferous tubules, which are tiny tubes where sperm are made. The epididymis is a curved tube where sperm mature, and it has 3 segments: the head, the body, and the tail. The scrotum is the wrinkly skin sac that holds the testicles, and the tunica albuginea is a protective white capsule surrounding the testicles. Then we have the transport system, which includes the vas deferens, a muscular tube that carries sperm upward, followed by the ejaculatory duct that merges sperm with fluids near the prostate, and then the urethra, which is a shared path for both urine and semen. Now listen carefully to the fluid factories, or semen makers. The seminal vesicles add sugary fluid that nourishes the sperm. The prostate contributes a milky fluid that protects the sperm. The bulbourethral glands, also called Cooper's glands, release pre-ejaculate lubricant that helps smooth the path. Next, the anatomy of the penis includes erectile tissues, 2 corpus cavernosum columns that become stiff, and the corpus spongiosum that cradles the urethra. The tip of the penis, called the glans, is the sensitive head and is covered by the prepuce or foreskin. To finish, let's review the structural layers and support. The layers of the penis go from skin to dartus fascia, then buccal fascia, and finally the tunica albuginea. The blood supply includes the dorsal artery and vein, the deep dorsal vein, and the deep artery. Supporting structures include the bladder, which stores urine and shuts off during sexual activity, the symphysis pubis, which is the pelvic bone anchoring various muscles, and the ampulla, which is the widened section of the vas deferens near the prostate. Now let's begin with genitourinary trauma, which is most commonly due to blunt trauma, such as motor vehicle collisions. Renal injury typically presents with bruises, flank pain, and hematuria, and it is caused by direct blows or lower rib fractures. Bladder injury may present with hematuria, suprapubic pain, and difficulty voiding. When the superior bladder wall, or dome, is injured due to direct trauma to a full bladder, such as from a seatbelt, it leads to an abrupt increase in intravesical pressure. This results in rupture of the dome, which is the weakest part, followed by accumulation of urine in the intraperitoneal space. Peritoneal absorption of urine subsequently leads to elevated BUN and creatinine levels. When the anterior bladder wall or neck is injured, usually by pelvic fracture and perforation from bony spicules, the urine accumulates extraperitoneally in the retropubic space. Now let's talk about urethral injury, which occurs almost exclusively in males. It presents with blood at the urethral meatus, hematuria, and difficulty voiding, and in such cases, urethral catheterization is relatively contraindicated. Anterior urethral injury results from a perineal stratal injury, causing disruption of the bulbar, or spongy, urethra, and leads to scrotal hematoma. If buccal fascia is torn, urine can escape into the perineal space. Posterior urethral injury typically results from a pelvic fracture, causing disruption at the bulbomembranous junction, which is the weakest part. This leads to urine leakage into the retropubic space and a high-riding prostate. In perforation of the spongy urethra due to rupture of buccal fascia, anterior urethral injury is confirmed, and torn deep penile fascia allows bloody extravasation, while in posterior urethral injury, the bulbomembranous junction and the retropubic space are involved. Now listen carefully to the autonomic innervation of the male sexual response. Erection is governed by the parasympathetic nervous system, specifically the pelvic splanchnic nerves from S2 to S4. Nitric oxide increases cGMP, causing smooth muscle relaxation and vasodilation, which promotes erection. On the other hand, norepinephrine increases intracellular calcium, leading to smooth muscle contraction, vasoconstriction, and suppression of erection. Emission is mediated by the sympathetic nervous system through the hypogastric nerve from T11 to L2, while expulsion involves visceral and somatic nerves, primarily the pudendal nerve. Remember the phrase, point, squeeze, and shoot, and the helpful mnemonic, S2, 3, for keep the penis off the floor. PDE5 inhibitors such as sildenafil inhibit cGMP breakdown, thus supporting erection. Now let's turn to the seminiferous tubules, where spermatogonia maintain the germ cell pool and produce primary spermatocytes, and they line the seminiferous tubules as germ cells. Sertoli cells, which are non-germ cells, secrete inhibin B to inhibit FSH and secrete androgen-binding protein to maintain local levels of testosterone. They produce Müllerian inhibiting factor, and tight junctions between adjacent Sertoli cells form the blood-testis barrier, which isolates gametes from autoimmune attack. These cells support and nourish developing spermatozoa, regulate spermatogenesis, and are temperature sensitive, leading to decreased sperm production and reduced inhibin B with elevated temperature. Sertoli cells also convert testosterone and androstenedione to estrogens via aromatase and are the homologs of female granulosa cells. Temperature increases, as seen in varicocele or cryptorchidism, negatively affect their function. Now let's finish by looking at Leydig cells, which are endocrine cells located in the interstitium. These cells secrete testosterone in response to LH, and their testosterone production is unaffected by temperature. Leydig cells are the homologs of female theca interna cells. The entire hormonal regulation begins at the hypothalamus, where GnRH stimulates the anterior pituitary to release LH and FSH. LH acts on Leydig cells to produce testosterone, while FSH acts on Sertoli cells, which then secrete androgen-binding protein and inhibin B. Testosterone and inhibin B provide feedback inhibition, and all these events occur around the lumen of the seminiferous tubule, with associated capillary support. Now let's talk about spermatogenesis, which begins at puberty with spermatogonia, and full development takes around 2 months. This entire process occurs in the seminiferous tubules and ultimately produces spermatids. These spermatids undergo spermiogenesis, which involves the loss of cytoplasmic contents and the gain of an acrosomal cap, resulting in the formation of mature spermatozoa. A useful way to remember this is, gonium is going to be a sperm, and zoon is zooming to the egg. Tail mobility is impaired in conditions like ciliary dyskinesia or Cardiganer syndrome, which leads to infertility. However, in cystic fibrosis, tail mobility is normal, but infertility results from an absent vas deferens. Now listen carefully to the sequence of development. It begins with the spermatogonium, which is diploid, with 2N and 2C. This develops into a primary spermatocyte, after interphase replication L diploid, but with 2N and 4C with 92 chromosomes. After meiosis I, it forms secondary spermatocytes, which are haploid with 1N and 2C. Then comes the spermatid after meiosis II, which are also haploid, now with 1N and 1C, and finally, it becomes a mature spermatozoon, still haploid, with 1N and 1C. The blood-testis barrier plays a critical role throughout this process, and tight junctions maintain this barrier. Turning to estrogen, its sources include the ovary, where estradiol is produced, the placenta, which makes estriol, and adipose tissue, which produces estrone through aromatization. In terms of potency, estradiol is the strongest, followed by estrone, and then estriol. Estradiol is specifically produced from the two ovaries. Estrogen functions to develop internal and external genitalia, breasts, and female fat distribution. It also supports follicular growth and endometrial proliferation while increasing myometrial excitability. It upregulates estrogen, LH, and progesterone receptors, provides feedback inhibition of FSH and LH until the LH surge, and stimulates prolactin secretion, though it reduces prolactin action on the breasts. And during pregnancy, there is a 50-fold increase in estradiol and estrone, and a 1,000-fold increase in estriol, which serves as an indicator of fetal well-being. Estrogen receptors are expressed in the cytoplasm and translocate to the nucleus once bound by estrogen. Now let's explain the pathway. Theca cells and granulosa cells both play essential roles. LH binds to receptors on theca cells and through CAMP, stimulates conversion of cholesterol to androstenedione. Androstenedione then moves to granulosa cells, where FSH binding leads to aromatase activation via CAMP, converting androstenedione into estrone and then estradiol. Now listen carefully as we shift to progesterone, which is produced by the corpus luteum, placenta, adrenal cortex, and testes. After delivery, the fall in estrogen and progesterone disinhibits prolactin, which leads to lactation. An increase in progesterone is a key indicator of ovulation, and it supports gestation. During the luteal phase, progesterone prepares the uterus for implantation of a fertilized egg. It stimulates endometrial glandular secretions and spiral artery development, produces thick cervical mucus to inhibit sperm entry into the uterus, and prevents endometrial hyperplasia. It also increases body temperature, reduces estrogen receptor expression, and inhibits gonadotropin secretion, including LH and FSH. During pregnancy, progesterone maintains the endometrial lining and sustains pregnancy. It reduces myometrial excitability, leading to decreased frequency and intensity of uterine contractions, and it also decreases prolactin action on the breasts, preventing premature lactation. Now let's talk about oogenesis, where the primary oocytes begin meiosis I during fetal life and complete meiosis I just prior to ovulation. Meiosis I is arrested in prophase I for many years until ovulation, and this arrest happens in primary oocytes. Then, meiosis II is arrested in metaphase II, but only until fertilization occurs, and this arrest takes place in secondary oocytes. If fertilization does not happen within 1 day, the secondary oocyte will degenerate. The process begins with the oogonium, which is diploid, with 2N and 2C. It progresses to a primary oocyte, still diploid, now with 2N and 4C. Next, after meiosis I, it becomes a secondary oocyte, which is haploid, with 1N and 2C, and finally turns into the ovum, which is haploid, with 1N and 1C. The polar bodies also emerge in this process, and they can degenerate or, in some cases, give rise to two polar bodies. Now listen carefully. During replication in interphase, the cell contains 46 single chromosomes. After replication, we see 92 sister chromatids. The arrest in prophase I continues until ovulation, while arrest in metaphase II remains until fertilization. Once meiosis is complete, we end up with 23 single chromosomes in the ovum, as well as in the polar bodies. The sequential steps of replication, followed by meiosis I and II, ensure the final ovum has the correct ploidy and chromatid number, indicated as 1N and 1C, ready for fertilization, and supported by tightly regulated timing and checkpoints within the meiotic process. Let's move to ovulation, which involves follicular rupture and the release of the secondary oocyte. This event is triggered by a sudden release of LH, known as the LH surge, occurring at mid-cycle. Under normal conditions, estrogen inhibits LH release, but high estrogen levels at mid-cycle transiently stimulate LH release, which causes the LH surge, and this leads directly to ovulation. Some individuals may experience a phenomenon called Mittelschmerz, or middle hurts, which is pain associated with ovulation. This pain arises due to peritoneal irritation from normal bleeding at the site of follicular rupture. It is typically mild and affects only one side, but sometimes it can mimic symptoms of acute appendicitis, especially when it occurs on the right side. Now let's explore the menstrual cycle, which consists of regular cyclic changes that periodically prepare the female reproductive system for fertilization and pregnancy. The cycle occurs in defined phases, based on events happening in both the ovaries and the uterus. From the first day of menses to ovulation is one phase, and from ovulation to the first day of the next menses is the second. Within the ovarian cycle, we begin with the follicular phase, where follicular development takes place. The later stages of this phase are stimulated by FSH, and its length can vary from cycle to cycle. Then comes the luteal phase, which involves the formation of the corpus luteum from the remnants of the follicle, stimulated by LH, and this phase lasts a fixed duration of 14 days, regardless of cycle length. Now listen carefully to the changes in the uterus. The uterine cycle starts with the proliferative phase, during which the endometrium begins to develop. This phase is stimulated by estrogen and features straight, narrow endometrial glands. Following this is the secretory phase, which prepares the endometrium for implantation of a fertilized egg. This preparation is driven by progesterone and results in tortuous, dilated endometrial glands. Altogether, the cycle spans approximately 28 days, starting with day 0, leading to ovulation at around day 14, and concluding by day 28. Throughout this period, various follicles develop, from primordial follicles to mature Graafian follicles, under tight hormonal control. Let's begin with abnormal uterine bleeding, which refers to any deviation from normal menstruation in terms of volume, duration, frequency, regularity, or the presence of intermenstrual bleeding. The causes are categorized using the POMC-ON system. Structural causes include polyp, adenomyosis, leiomyoma, and malignancy or hyperplasia. Non-structural causes include coagulopathy, ovulatory, endometrial, iatrogenic, and not yet classified categories. You should note that terms such as dysfunctional uterine bleeding, menorrhagia, metrorrhagia, polymenorrhea, and oligomenorrhea are no longer recommended, and have been replaced with this standardized terminology for clarity and precision. Now let's talk about pregnancy, beginning with fertilization, which most commonly occurs in the upper end of the fallopian tube, specifically the ampulla, and usually happens within 1 day of ovulation. Implantation in the uterine wall follows about 6 days after fertilization. At this point, syncytiotrophoblasts begin secreting HCG, which becomes detectable in the blood approximately 1 week after fertilization, and shows up on home urine pregnancy tests 2 weeks after fertilization. When it comes to dating pregnancy, embryonic or developmental age refers to the time since fertilization and is used in embryology, while gestational age refers to the time since the first day of the last menstrual period and is used clinically. Are you following me? Gravidity, or gravida, refers to the number of pregnancies, while parity, or para, refers to the number of pregnancies that resulted in live births. Over the course of pregnancy, placental hormone secretion generally increases, but human chorionic gonadotropin, or HCG, reaches its peak at about 8 to 10 weeks of gestation. During these weeks, there is a transition in the main source of hormones, moving from the corpus luteum to the placenta, and this luteal placental shift allows the placenta to take over production of essential hormones like progesterone and estrogens. Now let's explore the physiologic changes that occur in pregnancy. In the renal system, there is an increase in GFR, and this results in lower BUN and lower creatinine levels. Mild glucosuria and proteinuria can also occur. Hydronephrosis and hydroureter may develop, and are more prominent on the right side. On the skin, changes include melasma, linea nigra, darkening of the areola, striae gravidarum, varicose veins, and palmar erythema. In the gastrointestinal system, you may find constipation, gastroesophageal reflux disease, and an increased risk of gallstones. Now listen carefully. In the cardiovascular system, there is an increase in cardiac output and heart rate, especially in the later stages of pregnancy, and peripheral edema is also common. In the respiratory system, mild respiratory alkalosis can occur. The musculoskeletal system may show increased lordosis and joint laxity. Hematologic changes include dilutional anemia, a hypercoagulable state, and increased requirements for micronutrients. In terms of metabolism and hormones, there is increased insulin resistance and secretion, along with increased lipolysis and fat utilization. The pituitary enlarges, and there are increases in binding proteins such as TBG, CBG, and SHBG. Now let's talk more about human chorionic gonadotropin. Its source is the syncytial trophoblast of the placenta, and its function is to maintain the corpus luteum, and thus progesterone, for the first 8 to 10 weeks of gestation by acting like LH. Without this stimulation, luteal cells would regress, leading to abortion. After 8 to 10 weeks, the placenta is able to synthesize its own estriol and progesterone, and the corpus luteum degenerates. HCG is used to detect pregnancy because it appears early in urine. It has an identical alpha subunit to LH, FSH, and TSH, but its beta subunit is unique, which is why pregnancy tests target it. Are you ready to continue? HCG levels are elevated in multifetal gestation, hydatidiform moles, choriocarcinomas, and Down syndrome. On the other hand, HCG levels are decreased in ectopic or failing pregnancies, and in genetic syndromes like Edwards and Patel. Now let's discuss human placental lactogen, also called human chorionic somatomammatropin. It is also produced by the syncytial trophoblast of the placenta. Its function is to promote insulin resistance, which helps ensure that the growing fetus receives adequate glucose and amino acids. At the same time, it stimulates insulin secretion, and if the mother cannot overcome the insulin resistance, this may lead to gestational diabetes. Now let's review the APGAR score, which is an assessment of newborn vital signs following delivery, based on a 10-point scale evaluated at 1 minute and again at 5 minutes after birth. The score is based on appearance, pulse, grimace, activity, and respiration. A pink color gets a full score, while pale or blue earns none. A pulse of 100 beats per minute or more is ideal, while no pulse scores 0. Strong crying with active movement is best, while a weak cry or no response scores less. APGAR scores less than May 7 require further evaluation, and if the score remains low over time, there is an increased risk the child may develop long-term neurologic damage. And lastly, let's go over neonatal birth weight. Low birth weight is defined as less than 2,500 grams, while high birth weight or macrosomia is defined as more than 4,000 grams. Low birth weight is usually associated with prematurity or fetal growth restriction, while high birth weight may stem from fetal factors such as constitutional or genetic traits, or maternal factors such as obesity and diabetes mellitus. Complications of low birth weight include increased mortality, including sudden infant death syndrome, and increased morbidity. On the other hand, high birth weight carries an increased risk of maternal or fetal trauma, such as shoulder dystocia during delivery. After parturition and delivery of the placenta, there is a rapid decrease in estrogen and progesterone, and this disinhibits prolactin, which then initiates lactation. Suckling is required to maintain both milk production and ejection, because increased nerve stimulation leads to increased oxytocin and prolactin. Now listen carefully. Prolactin induces and maintains lactation and reduces reproductive function, while oxytocin assists in milk letdown and also promotes uterine contractions. Breast milk, which is the ideal nutrition for infants less than 6 months old, contains immunoglobulins, mostly IgA, along with macrophages and lymphocytes, and it helps reduce infant infections. It is also associated with a reduced risk for the child to develop asthma, allergies, diabetes mellitus, and obesity. You should remember this: exclusively breastfed infants should receive vitamin D and possibly iron supplementation, and breastfeeding reduces maternal risk of breast and ovarian cancer and also facilitates mother-child bonding. Now let's talk about menopause, which is diagnosed after 12 months of amenorrhea. Estrogen production decreases due to an age-linked decline in the number of ovarian follicles, and the average age at onset is 51 years, although it can occur earlier in people who smoke tobacco. Usually, this phase is preceded by 4 to 5 years of abnormal menstrual cycles, and after menopause, the source of estrogen becomes estrone, which comes from peripheral conversion of androgens, and this increase in androgens may lead to hirsutism. Are you following me? Follicle-stimulating hormone, or FSH, rises significantly and is a specific marker for menopause due to the loss of negative feedback from reduced estrogen. The hormonal changes you should remember include decreased estrogen, markedly increased FSH, mildly increased LH without a surge, and increased GnRH. Now listen carefully. The clinical symptoms can be summarized as havocs, hot flashes, atrophy of the vagina, osteoporosis due to increased osteoclast activity, coronary artery disease, and sleep disturbances. Hormone replacement therapy, or HRT, is sometimes used to treat menopausal symptoms, but it can increase the risk of breast and endometrial cancer, cardiovascular disease, stroke, and thromboembolism. If menopause occurs before the age of 40, it suggests primary ovarian insufficiency, or premature ovarian failure, which may be seen in females who have received chemotherapy or radiation therapy. Now let's move on to androgens, which include testosterone, dihydrotestosterone or DHT, dehydroepiandrosterone or DHEA, and androstenedione. These androgens come from different sources. Testosterone and DHT are produced by the testis, while DHEA and androstenedione come from the adrenal glands. The potency goes in this order: DHT is stronger than testosterone, which is stronger than androstenedione, which is stronger than DHEA. Testosterone is responsible for the differentiation of the epididymis, vas deferens, and seminal vesicles, which are internal genitalia except for the prostate, and it also promotes the growth spurt, including the penis, seminal vesicles, sperm, muscle, and red blood cells. In addition, it causes deepening of the voice, and closing of the epiphyseal plates through estrogen converted from testosterone, and it also drives libido. Now listen carefully. DHT has both early and late functions. Early in development, it causes differentiation of the penis, scrotum, and prostate, while later it contributes to prostate growth, androgenetic alopecia, and sebaceous gland activity. Testosterone is converted to DHT by the enzyme 5-alpha reductase, which is inhibited by finasteride. In males, androgens are converted to estrogens by the enzyme aromatase, mainly in adipose tissue and the testes. When it comes to anabolic androgenic steroid use, it leads to increased fat-free mass, muscle strength, and performance, but you should suspect it in males who present with behavior changes like aggression, as well as acne, gynecomastia, and erythrocytosis, which increases the risk of thromboembolism. The testes may become small due to inhibition of the hypothalamic pituitary gonadal axis by exogenous testosterone, leading to reduced intratesticular testosterone, decreased testicular size, reduced sperm count, and sometimes azoospermia. In females, anabolic steroid use may result in virilization, including hirsutism, acne, breast atrophy, and androgenetic alopecia. Sexual maturity rating, also known as Tanner stage, is used to assess pubertal development, and it is assigned independently to genitalia, pubic hair, and breast, which means a person can have stage 2 genitalia and stage 3 pubic hair at the same time. The earliest detectable secondary sexual characteristic is breast bud development in females, while in males, it is testicular enlargement. In stage 1, which is prepubertal, there is no sexual hair. Around 8 to 11.5 years, which is stage 2, pubic hair begins to appear, a process called pubarch, and testicular enlargement occurs in males, while females develop a breast bud, also known as thelarch, with a mound forming. By stage 3, around 11.5 to 13 years, pubic hair becomes coarser, the penis starts to increase in size or length, and the breast continues to enlarge. Then, in stage 4, around 13 to 15 years, coarse hair appears across the pubis but spares the thighs, the penis widens and the glans becomes more defined, and the breast enlarges further, with the areola becoming raised and forming a mound-on-mound appearance. Finally, in stage 4, which usually occurs after age 15, coarse hair covers the pubis and extends to the medial thighs, the penis and testis reach adult size, and the breast develops an adult contour with a flattened areola. Now let's talk about precocious puberty, which refers to the appearance of secondary sexual characteristics like pubarch or thelarch before age 8 in females and 9 in males. Increased sex hormone exposure or production leads to increased linear growth, somatic and skeletal maturation, and premature closure of epiphyseal plates, which can result in short stature. There are different types. Central precocious puberty involves increased GnRH secretion and is most often idiopathic, caused by early activation of the hypothalamic pituitary gonadal axis, though it can also be due to CNS tumors. Peripheral precocious puberty, which is GnRH independent, involves increased sex hormone production or exposure to exogenous sex steroids, and this can occur in conditions like congenital adrenal hyperplasia, estrogen-secreting ovarian tumors such as granulosa cell tumors, Leydig cell tumors, or McCune-Albright syndrome. Delayed puberty is defined by the absence of secondary sexual characteristics by age 13 in females and age 14 in males. The causes can be categorized into hypergonadotropic hypogonadism and hypogonadotropic hypogonadism. In hypergonadotropic hypogonadism, also known as primary hypogonadism, conditions like Klinefelter syndrome, Turner syndrome, or gonadal injury from chemotherapy, radiotherapy, or infections are responsible. On the other hand, hypogonadotropic hypogonadism, or secondary hypogonadism, can be caused by constitutional delay of growth and puberty, often referred to as late blooming, Kallmann syndrome, or CNS lesions. Now listen carefully. When it comes to sex chromosome disorders, aneuploidy is most commonly due to meiotic non-disjunction. In Klinefelter syndrome, the individual is male with a 47XXY karyotype. These patients often have small, firm testes, infertility due to azoospermia, tall stature with eunuchoid proportions, and gynecomastia, along with female pattern hair distribution. Developmental delay may also be present. The presence of an inactivated X chromosome, or bar body, is typical. It is a common cause of hypogonadism identified during infertility workups, and there is an increased risk of breast cancer. Dysgenesis of the seminiferous tubules results in reduced inhibin B and elevated FSH, while abnormal Leydig cell function leads to reduced testosterone and elevated LH. Now let's discuss Turner syndrome, which occurs in females with a 45XO karyotype. These individuals are typically short in stature, a trait that can be managed with growth hormone therapy, and they present with ovarian dysgenesis or streak ovaries, a broad chest with widely spaced nipples, and cardiovascular anomalies like bicuspid aortic valve and coarctation of the aorta, which presents with femoral pulses weaker than brachial pulses. There are also lymphatic defects, leading to a webbed neck or cystic hygroma, and lymphedema in the feet and hands, as well as other features like a horseshoe kidney, a high-arched palate, and shortened fourth metacarpals. Turner syndrome is the most common cause of primary amenorrhea. There is no bar body, and menopause occurs before menarche due to reduced estrogen, which causes elevated LH and FSH levels. The chromosomal loss is often due to non-disjunction during meiosis, especially in paternal gametes, leading to sperm missing the sex chromosome. Alternatively, mitotic errors after zygote formation can result in mosaic karyotypes such as 45X/46XX. Mosaicism involving 45X/46XY is associated with an increased risk for gonadoblastoma. Pregnancy is possible in some Turner syndrome cases with IVF and treatment using exogenous estradiol, 17-beta and progesterone. Now, regarding double Y males with a 47XYY karyotype, these individuals are usually phenotypically normal and often go undiagnosed. They tend to be very tall and have normal fertility. However, some may present with severe acne, learning disabilities, or features of autism spectrum disorders. Finally, other disorders of sex development, previously referred to as intersex states, involve a discrepancy between phenotypic sex, which is determined by external genitalia and influenced by hormone levels, and gonadal sex, which refers to whether testes or ovaries are present and corresponds with the presence of a Y chromosome. In 46XXDSD, ovaries are present but external genitalia are virilized or atypical, most often due to congenital adrenal hyperplasia from excessive androgen exposure early in development. In contrast, 46XY-DSD involves testes being present but with feminized or atypical external genitalia, most commonly caused by androgen insensitivity syndrome due to a defect in the androgen receptor. In ovotesticular DSD, which occurs more often in 46XX individuals than 46XY, both ovarian and testicular tissues are present, also known as ovotestis, and this results in atypical genitalia. Now listen carefully. When diagnosing disorders by sex hormones, we look at the levels of testosterone and luteinizing hormone, or LH. When both testosterone and LH are increased, the diagnosis is androgen insensitivity syndrome. However, when testosterone is high and LH is low, it points to a testosterone-secreting tumor or the use of exogenous androgenic steroids. On the other hand, when testosterone is low and LH is high, this indicates hypergonadotropic, or primary, hypogonadism. And finally, if both testosterone and LH are low, this points to hypogonadotropic, or secondary, hypogonadism. Are you following me? Let's now talk about diagnosing disorders using physical characteristics. If the uterus is present but breasts are absent, the diagnosis is either hypergonadotropic hypogonadism in a genotypic female or hypogonadotropic hypogonadism in a genotypic female. However, if the uterus is absent but breasts are present, the diagnosis could be Müllerian agenesis in a genotypic female or androgen insensitivity syndrome in a genotypic male. Now let's explore aromatase deficiency, which is an inability to synthesize endogenous estrogens, and this condition is inherited in an autosomal recessive pattern. During fetal life, dehydroepiandrosterone, or DHEA, produced by fetal adrenal glands cannot be converted to estrogen by the placenta, and instead is converted to testosterone peripherally. This leads to virilization of both the female infant, resulting in atypical genitalia, and the mother, who may experience acne and hirsutism, because fetal androgens can cross the placenta. Next, let's examine androgen insensitivity syndrome, which results from a defect in the androgen receptor, producing a female-appearing genetic male with a 46XY karyotype. These individuals develop breast tissue and female external genitalia, but have scant axillary and pubic hair and a rudimentary vagina. The uterus and fallopian tubes are absent due to the continued action of anti-Müllerian hormone from the testes. Functioning testes are present and often located in the labia majora, and these are usually surgically removed to prevent malignancy. Levels of testosterone, estrogen, and LH are elevated compared to sex chromosome disorders. Are you ready for more? In 5-alpha reductase deficiency, which is inherited in an autosomal recessive manner and affects only genetic males, there is an inability to convert testosterone to dihydrotestosterone, or DHT. This leads to atypical genitalia at birth, but at puberty, the increase in testosterone causes masculinization and growth of external genitalia. Despite the enzyme deficiency, testosterone and estrogen levels remain normal, and LH is either normal or increased. Internal genitalia are also normal in these individuals. Now listen carefully. Kallmann syndrome is a failure to complete puberty and is classified as a form of hypogonadotropic hypogonadism. This condition arises due to defective migration of neurons, which results in the failure of the olfactory bulbs to develop. Consequently, there is decreased synthesis of GnRH in the hypothalamus, and patients typically have hyposmia or anosmia. Hormone levels such as GnRH, FSH, LH, and testosterone are all reduced. The condition causes infertility, with low sperm count in males and amenorrhea in females. Let's now turn to placental disorders, beginning with placenta accreta spectrum. This includes abnormal invasion of trophoblastic tissue into the uterine wall, and the risk is increased with prior caesarean section or other uterine surgeries, placenta previa, advanced maternal age, and multiparity. Depending on the depth of invasion, the spectrum includes placenta accreta, which attaches to the myometrium without invading it, and is the most common type, placenta increta, which partially invades into the myometrium, and placenta percreta, which completely invades through the myometrium and serosa, sometimes reaching adjacent organs like the bladder, leading to hematuria. Now let's talk about the clinical presentation of placenta accreta spectrum, which includes difficulty separating the placenta from the uterus after delivery and severe postpartum hemorrhage when manual removal of the placenta is attempted. Often, the placenta must be extracted in pieces. The definitive treatment in such cases is hysterectomy, which ensures maternal safety. Now listen carefully. Placenta previa is characterized by the attachment of the placenta over the internal cervical os, essentially giving a preview of the placenta through the cervix. Risk factors include prior C-section and multiparity. It typically presents with painless vaginal bleeding during the third trimester. A related condition, low-lying placenta, refers to the placenta being located less than 2 cm from, but not covering, the internal cervical os, and this proximity may still pose a risk during delivery. Are you following me? In vasa previa, fetal vessels run over or close to the internal cervical os, within 2 cm. This is often associated with velamentous insertion of the umbilical cord, where the cord inserts into the chorioamniotic membrane rather than directly into the placenta, leaving fetal vessels unprotected by Wharton jelly. It can also occur with bilobed or sexcentariate placentas. Clinically, it presents as painless vaginal bleeding upon membrane rupture, often accompanied by fetal heart rate abnormalities like bradycardia. Without prompt recognition, this can lead to fetal death from exsanguination. Finally, let's discuss placental abruption, also known as abruptio placentae, which is the premature separation of the placenta from the uterus before delivery. Major risk factors include maternal hypertension, preeclampsia, smoking, cocaine use, and abdominal trauma. The clinical presentation is abrupt and painful vaginal bleeding in the third trimester. This condition may lead to maternal hypovolemic shock due to hemorrhage, and disseminated intravascular coagulation due to the release of tissue factor from the injured placenta. It can also cause fetal distress, such as hypoxia, and may be life-threatening for both mother and fetus. Now let's talk about uterine rupture, which is defined as a full-thickness disruption of the uterine wall. Risk factors include a prior cesarean section, especially during labor in a subsequent pregnancy, and abdominal trauma. The condition presents with painful vaginal bleeding, along with fetal heart rate abnormalities such as bradycardia. Fetal parts may become easily palpable through the abdominal wall, and there may be a loss of fetal station. This situation can be life-threatening for both the mother and the fetus, making prompt diagnosis and intervention critical. Now listen carefully. Postpartum hemorrhage is defined as greater than expected blood loss after delivery, and it remains the leading cause of maternal mortality worldwide. The etiology can be remembered using the 4 T's, tone, which refers to uterine atony and presents as a soft, boggy uterus, and is the most common cause, trauma, which includes lacerations, incisions, or uterine rupture, tissue, which means retained products of conception, and thrombin, which indicates coagulopathy. Initial treatment includes uterine massage and administration of oxytocin. If bleeding is refractory to these measures, surgical ligation of the uterine or internal iliac arteries may be performed. Fertility is preserved because the ovarian arteries provide collateral circulation. Are you following me? Now let's talk about ectopic pregnancy, which involves the implantation of a fertilized ovum in a site other than the uterus, most commonly in the ampulla of the fallopian tube. Risk factors include tubal pathologies like scarring from salpingitis or pelvic inflammatory disease, prior ectopic pregnancy, intrauterine device use, and in vitro fertilization. Clinically, it presents with first trimester bleeding and lower abdominal pain, and it is often mistaken for appendicitis. You should suspect ectopic pregnancy in patients with a history of amenorrhea and a lower than expected rise in HCG based on gestational age. Diagnosis is confirmed with ultrasound, which may reveal an extravarian adnexal mass. Treatment options include methotrexate or surgical intervention, depending on the severity and clinical stability of the patient. Now let's move on to hydatidiform mole, which is characterized by cystic swelling of chorionic villi and proliferation of chorionic epithelium, specifically involving only the trophoblast. It typically presents with vaginal bleeding, emesis, and uterine enlargement that is more than expected for gestational age. Patients may also report pelvic pressure or pain. The condition is associated with HCG-mediated effects, including hyperthyroidism, theca lutein cysts, hyperemesis gravidarum, and early-onset preeclampsia occurring before 20 weeks of gestation. Treatment involves dilation and curettage, and methotrexate may be used. After treatment, HCG levels must be monitored carefully. Now let's differentiate between complete and partial moles. The complete mole most commonly has a 46XX or 46XY karyotype, and it results from an enucleated egg fertilized by a single sperm that duplicates its DNA. In contrast, a partial mole has a triploid karyotype, such as 69XXX, 69XXY, or 69XYY, and it arises from the fertilization of an egg by two sperm. Histologically, complete moles show hydropic villi with circumferential and diffuse trophoblastic proliferation, while partial moles show only some hydropic villi and minimal or focal trophoblastic proliferation. Fetal parts are absent in complete moles but present in partial moles. Now listen carefully. When staining for p57 protein, which is maternally expressed, complete moles are negative because they lack maternal genetic material, while partial moles are positive. A useful mnemonic is that a complete mole is completely male and lacks maternal contribution. Uterine size tends to be increased in complete moles but not in partial moles. Levels of HCG are markedly elevated in complete moles and only moderately elevated in partial moles. On imaging, complete moles may appear as a honeycombed uterus or clusters of grapes, and a snowstorm appearance may be seen on ultrasound. Partial moles, on the other hand, may show fetal parts on imaging. Finally, let's talk about the risks. The risk of developing an invasive mole is about 15 to 20% with a complete mole but less than 5% with a partial mole. The risk of progression to choriocarcinoma is about 2% with complete moles and is considered rare in partial moles. These distinctions are essential for diagnosis, management, and follow-up of patients presenting with gestational trophoblastic disease. Now let's begin with choriocarcinoma, which is a rare malignancy of trophoblastic tissue involving cytotrophoblasts and syncytiotrophoblasts, but without the presence of chorionic villi. It most commonly occurs after an abnormal pregnancy, such as a hydatidiform mole or abortion, although it can also arise non-gestationally in the gonads. Clinically, it presents with abnormal uterine bleeding, and symptoms associated with HCG-mediated effects. Patients may also experience dyspnea and hemoptysis. The malignancy spreads hematogenously to the lungs, where it may form characteristic, cannonball, metastases. Treatment involves administration of methotrexate, which can be curative. Now let's talk about hypertension in pregnancy, starting with gestational hypertension, which is defined as blood pressure greater than 140/90 mm of mercury after 20 weeks of gestation. It occurs without pre-existing hypertension, proteinuria, or end organ damage. If hypertension is present before 20 weeks of gestation, it suggests chronic hypertension. Management includes antihypertensive medications such as hydralazine, alpha-methyldopa, labetalol, and nifedipine. Delivery is typically planned between 37 and 39 weeks of gestation. A helpful mnemonic is that hypertensive moms love nifedipine, as it is safe and effective. Now listen carefully. Preeclampsia is defined as new-onset hypertension occurring after 20 weeks of gestation along with either proteinuria or end organ dysfunction. If it begins before 20 weeks, molar pregnancy should be suspected. It is caused by abnormal development of placental spiral arteries, leading to endothelial dysfunction, vasoconstriction, and ischemia. Risk factors include a history of preeclampsia, multifetal gestation, nulliparity, chronic hypertension, diabetes, chronic kidney disease, autoimmune diseases such as antiphospholipid syndrome, and obesity. Complications can include placental abruption, coagulopathy, renal failure, pulmonary edema, and uteroplacental insufficiency. This condition may progress to eclampsia or HELLP syndrome. Treatment involves antihypertensives and intravenous magnesium sulfate for seizure prevention, while definitive treatment is delivery. Prophylactic use of aspirin may be recommended. Are you following me? Eclampsia is diagnosed when preeclampsia is accompanied by seizures. It is a life-threatening condition that can result in death due to stroke, intracranial hemorrhage, or acute respiratory distress syndrome. Treatment includes intravenous magnesium sulfate to prevent further seizures, antihypertensive therapy, and immediate delivery regardless of gestational age to protect both mother and fetus. Now let's discuss HELLP syndrome, which is a severe complication of preeclampsia involving thrombotic microangiopathy of the liver. It stands for hemolysis, elevated liver enzymes, and low platelets. Notably, it may occur even in the absence of hypertension and proteinuria. Blood smear typically reveals schistocytes, which are fragmented red cells. HELLP syndrome can lead to hepatic subcapsular hematomas, and if these rupture, the patient may experience severe hypotension. Additionally, disseminated intravascular coagulation can occur due to the release of tissue factor from the injured placenta. The definitive treatment for HELLP syndrome is immediate delivery of the fetus. Now listen carefully. Supine hypotensive syndrome, also known as aortocaval compression syndrome, typically appears after 20 weeks of gestation. When a pregnant woman lies in the supine position, the gravid uterus compresses the abdominal aorta and inferior vena cava. This reduces placental perfusion, which can lead to pregnancy loss, and also decreases venous return, resulting in hypotension. The condition is relieved when the mother is positioned in the left lateral decubitus position, allowing for improved blood flow and symptom relief. Now let's explore the epidemiology of gynecologic tumors in the United States. Endometrial cancer has the highest incidence, followed by ovarian and then cervical cancer. However, cervical cancer is more common worldwide due to limited access to screening and lack of HPV vaccination. In terms of prognosis, cervical cancer has the best outcome and is typically diagnosed before the age of 45. Endometrial cancer is usually seen in middle-aged women, around 55 years old. Ovarian cancer, which generally presents after the age of 65, has the worst prognosis. A useful mnemonic is that CEOs often go from best to worst as they get older. Now let's shift to vulvar pathology, beginning with non-neoplastic conditions such as Bartholin cyst and abscess. These result from blockage of the Bartholin gland duct, causing fluid to accumulate within the gland. This can eventually lead to abscess formation secondary to obstruction and inflammation. It most commonly occurs in reproductive age females and may present with pain and swelling. Another non-neoplastic condition is lichen sclerosis, a chronic, progressive inflammatory disorder characterized by porcelain white plaques that may become hemorrhagic, eroded, or ulcerated. It may also extend to the anus, creating a figure eight appearance. Incidence is increased in prepubertal and peri- or postmenopausal females. Common symptoms include intense pruritus, dyspareunia, dysuria, and dyschezia. Although benign, it carries a slightly increased risk for squamous cell carcinoma. Now let's finish with lichen simplex chronicus, which involves hyperplasia of the vulvar squamous epithelium. It presents as leathery, thickened vulvar skin with exaggerated skin markings, resulting from chronic rubbing or scratching. This condition is benign and does not carry a risk of squamous cell carcinoma. In contrast, vulvar carcinoma is a neoplastic condition arising from the squamous epithelial lining of the vulva and is usually diagnosed in postmenopausal females. It presents with leukoplakia, and a biopsy is often necessary to differentiate it from other causes. HPV-related vulvar carcinoma is associated with high-risk types 16 and 18, while non-HPV-related carcinoma usually develops after long-standing lichen sclerosis. Finally, extramammary Paget disease is an intraepithelial adenocarcinoma and represents a carcinoma in situ with low risk of underlying invasive disease. This differs from Paget disease of the breast, which is always associated with an underlying carcinoma. Clinical signs include pruritus, erythema, crusting, and ulcer formation. Now listen carefully. Imperfect hymen is caused by incomplete degeneration of the central portion of the hymen, and this can lead to accumulation of vaginal mucus at birth, which results in a self-resolving bulge in the introitus. However, if left untreated, it leads to primary amenorrhea, cyclic abdominal pain, and hematocolpos, which is the accumulation of menstrual blood in the vagina, leading to a bulging and bluish hymenal membrane. As we transition into vaginal tumors, you should remember that squamous cell carcinoma is usually secondary to cervical squamous cell carcinoma, since primary vaginal carcinoma is rare. But clear cell adenocarcinoma arises from vaginal adenosis, which is the persistence of glandular columnar epithelium in the proximal vagina, and is found in females who had exposure to diethylstilbestrol in utero. Are you following me? Sarcoma botryoides is another important tumor type, and it's an embryonal rhabdomyosarcoma variant that affects females less than 4 years old, with spindle-shaped cells that are Desmond positive. It presents with a clear, grape-like, polypoid mass emerging from the vagina. Now let's talk about anovulatory infertility, which is infertility secondary to lack of ovulation. The causes include polycystic ovary syndrome, primary ovarian insufficiency, hypogonadotropic hypogonadism, and hyperprolactinemia. However, you should remember that anovulation is considered normal during pregnancy, breastfeeding, and near menarche or menopause. Moving forward, polycystic ovary syndrome, or PCOS, has an unknown cause but is associated with dysregulation of ovarian steroidogenesis. It features increased LH to FSH ratio, increased androgens such as testosterone from the theca interna cells, and a reduced rate of follicular maturation, which leads to unruptured follicles or cysts and causes anovulation. This condition is a common cause of reduced fertility in females, and it's diagnosed based on 2 or more of the following: cystic or enlarged ovaries on ultrasound, oligo, or anovulation, and hyperandrogenism such as hirsutism or acne. It's also associated with obesity, insulin resistance, and acanthosis nigricans, and there is an increased risk of endometrial cancer due to unopposed estrogen from repeated anovulatory cycles. Now listen carefully. Treatment for PCOS includes cycle regulation through weight reduction, which decreases peripheral estrone formation, and oral contraceptive pills that prevent endometrial hyperplasia due to unopposed estrogen. Ovulation induction is used for infertility, and spironolactone, finasteride, or flutamide may be used to treat hirsutism. On the other hand, primary ovarian insufficiency, also called premature ovarian failure, is caused by premature atresia of ovarian follicles in females of reproductive age. It is most often idiopathic but is associated with chromosomal abnormalities such as Turner syndrome and Fragile X syndrome premutation, as well as autoimmunity. Karyotype screening is necessary, and patients typically present with signs of menopause after puberty but before age 40, with reduced estrogen and increased LH and FSH. Are you ready? Functional hypothalamic amenorrhea, also called exercise-induced amenorrhea, results from severe caloric restriction, increased energy expenditure, and stress, which cause a functional disruption of pulsatile GnRH secretion, leading to reduced LH, FSH, and estrogen. This pathogenesis involves reduced leptin due to decreased fat and increased cortisol from stress or excessive exercise. It is associated with eating disorders and the so-called female athlete triad, which includes low calorie availability or excessive exercise, low bone mineral density, and menstrual dysfunction. Now let's turn to cervical pathology, starting with dysplasia and carcinoma in situ, which is disordered squamous epithelial growth beginning at the basal layer of the squamocolumnar junction, or transformation zone, and extending outward. You should remember this: dysplasia is classified as CIN1, CIN2, or CIN3, with severe dysplasia or carcinoma in situ being unlikely to return to normal. It is associated with HPV-16 and HPV-18, which produce the E6 gene product that inhibits TP53, and the E7 gene product that inhibits PRB. A good mnemonic is 6 before 7 and P before R. You know koilocytes, which are cells with a wrinkled, racinoid nucleus and paranuclear halo, are pathognomonic of HPV infection. If left untreated, this may slowly progress to invasive carcinoma. Typically, it's asymptomatic and detected with a Pap smear, though it may present as abnormal vaginal bleeding, often postcoital. Risk factors include multiple sexual partners, HPV infection, smoking, early coitarch, DES exposure, and immunocompromise such as in HIV or transplant patients. Now let's move into invasive carcinoma, which is often squamous cell carcinoma. Pap smear screening is effective at detecting cervical dysplasia before it becomes invasive. Diagnosis is confirmed through colposcopy and biopsy. When the cancer invades laterally, it can block the ureters, leading to hydronephrosis and eventually renal failure. As we shift focus, primary dysmenorrhea is another topic to know well. It's painful menses caused by uterine contractions that reduce blood flow, resulting in ischemic pain. This is mediated by prostaglandins, and treatment includes NSAIDs, acetaminophen, and hormonal contraceptives. Finally, ovarian cysts are usually asymptomatic, but they can rupture, become hemorrhagic, or cause adnexal torsion. Follicular cysts are functional or physiologic cysts and are the most common ovarian mass in young females. These are caused by failure of a mature follicle to rupture and ovulate, and they may produce excess estrogen. Fortunately, they usually resolve spontaneously. Similarly, corpus luteal cysts are functional cysts caused by failure of the corpus luteum to involute after ovulation. These may produce excess progesterone and typically resolve on their own. Theca lutein cysts, also called hyperreactio luteinalis, are due to HCG overstimulation, are often bilateral or multiple, and are associated with gestational trophoblastic disease, such as hydatidiform mole or choriocarcinoma. Now let's talk about ovarian tumors, which are the most common adnexal mass in females older than 55 years. They present with abdominal distension, bowel obstruction, and pleural effusion. The risk increases with advanced age, a greater number of lifetime ovulations like early menarche, late menopause, or nulliparity, and is also elevated in conditions like endometriosis and genetic predisposition such as BRCA1, BRCA2 mutations, or Lynch syndrome. On the other hand, risk is reduced with a history of previous pregnancy, breastfeeding, oral contraceptive use, or tubal ligation. Epithelial tumors are often serous, lined by epithelium normally found in fallopian tubes, and are frequently bilateral, or mucinous, which are lined by epithelium typically found in the cervix. Response to therapy and relapse can be monitored using CA-125 levels, although it is not a good screening tool. Germ cell tumors may differentiate into somatic structures like teratomas, or extraembryonic ones like yolk sac tumors, and some remain undifferentiated, such as dysgerminomas. Sex cord stromal tumors, in contrast, develop from embryonic sex cords and stromal components, which give rise to follicular cells like theca and granulosa, or testicular cells like Sertoli and Leydig. Now listen carefully, because epithelial tumors come in several forms. Serous cystadenoma is benign and is the most common ovarian neoplasm, lined by fallopian tube-like epithelium. Mucinous cystadenoma is also benign, multiloculated, and large, and is lined by mucus-secreting epithelium. The Brenner tumor is usually benign too, showing nests of urothelial-like epithelium with characteristic, coffee bean, nuclei. Serous carcinoma, however, is the most common malignant ovarian neoplasm and is notable for the presence of somoma bodies. Mucinous carcinoma is a rare malignant tumor that may be metastatic from appendiceal or other gastrointestinal sources and can result in pseudomyxoma peritonia, which is the accumulation of mucinous material in the peritoneal cavity, also known as omental caking. Are you following me? Good, because now we're focusing on germ cell tumors. The mature cystic teratoma, also called a dermoid cyst, is benign and is the most common ovarian tumor in young females. It is a cystic mass that contains elements from all three germ layers, including teeth, hair, and sebum. It can be painful due to ovarian enlargement or torsion. There is a monodermal form with thyroid tissue, known as struma ovarii, which may present with hyperthyroidism. Although rare, malignant transformation may occur, usually to squamous cell carcinoma. Immature teratoma, by contrast, is malignant and aggressive, containing fetal tissue and neuroectoderm. It is usually diagnosed before age 20 and commonly presents with immature or embryonic-like neural tissue. Dysgerminoma is also malignant and most common in adolescents. It is the female equivalent of male seminoma but is rarer. Histologically, it shows sheets of uniform, fried egg cells, and tumor markers include increased HCG and LDH. Now let's explore yolk sac tumors, also known as endodermal sinus tumors. These are malignant and aggressive, appearing as yellow, friable, and hemorrhagic masses. About 50% contain Schiller-Duval bodies, which resemble glomeruli. The tumor marker is increased AFP, and these tumors occur in children and young adult females. Next, we move to sex cord stromal tumors. Fibroma is benign and composed of spindle-shaped fibroblasts. Meiggs syndrome refers to the triad of ovarian fibroma, ascites, and pleural effusion. Patients often describe a pulling sensation in the groin. The coma is mostly benign but may produce estrogen, and it usually presents as abnormal uterine bleeding in postmenopausal females. Sertoli-Leydig cell tumors are benign gray to yellow-brown masses that resemble testicular histology, with seminiferous tubules lined by Sertoli cells and surrounded by Leydig cells. These tumors may produce androgens, resulting in virilization like hirsutism, androgenetic alopecia, or clitoral enlargement. And now, moving on to granulosa cell tumors, which are the most common malignant sex cord stromal tumors. These typically occur in females in their 50s and often produce estrogen or progesterone. Clinical presentations include postmenopausal bleeding, endometrial hyperplasia, sexual precocity in preadolescence, and breast tenderness. Histology reveals Kollexner bodies, where granulosa cells are arranged haphazardly around collections of eosinophilic fluid that resemble primordial follicles. The tumor marker to remember here is increased inhibin. Just think, give Granny a call. Now let's turn to uterine conditions. First, consider non-neoplastic conditions. Adenomyosis involves the presence of endometrial tissue, including glands and stroma, within the myometrium. It may result from invagination of the basal layer of the endometrium or metaplasia of remnant progenitor cells. Symptoms include abnormal uterine bleeding and dysmenorrhea, with a diffusely enlarged and boggy uterus found on examination. Endometriosis, on the other hand, involves endometrial tissue located outside the uterus, possibly due to retrograde menstruation, lymphatic or hematogenous spread, or progenitor cell metaplasia. This condition presents with dysmenorrhea, dyspareunia, infertility, and abnormal uterine bleeding. Physical exams are often normal, but may occasionally reveal a mobile uterus, adnexal mass, uterosacral tenderness, or nodularity, though these findings are not diagnostic. Common pelvic sites include the superficial peritoneum, which may show yellow-brown, powder-burn lesions, and the ovaries, which form blood-filled chocolate cysts known as endometriomas. Are you ready for more? Let's now discuss endometrial hyperplasia, which is an abnormal proliferation of endometrial glands, usually due to excess estrogen unopposed by progesterone. It is associated with obesity, chronic anovulation such as in PCOS, nulliparity, hormone replacement therapy, and tamoxifen use. The main symptom is abnormal uterine bleeding, and there is an increased risk of developing endometrial carcinoma, especially if nuclear atypia is present. Endometritis refers to inflammation of the endometrium, usually following delivery when vaginal microbiota enter the uterine cavity. Caesarean section is the most important risk factor, as sutures and necrotic tissue provide a nidus for polymicrobial infection. Clinical signs include fever, uterine tenderness, and purulent lochia. Intrauterine adhesions, also known as Asherman syndrome when symptomatic, consist of fibrous bands within the endometrial cavity, typically resulting from basal layer damage after dilation and curettage. Symptoms include reduced menstrual flow, infertility, recurrent pregnancy loss, and dysmenorrhea. Now listen carefully, because neoplastic uterine conditions also demand attention. Leiomyomas, or fibroids, are benign tumors of the myometrium and are the most common gynecological tumor. They occur in reproductive age females, with increased incidence in the Black population. These tumors are often multiple and classified by their location as submucosal, intramural, or subserosal. While often asymptomatic, they may cause abnormal uterine bleeding, pelvic pain or pressure, and reproductive issues. They are estrogen sensitive, increasing in size during pregnancy and shrinking after menopause. On examination, the uterus is enlarged and has a nodular contour. Histologically, fibroids display a whorled pattern of smooth muscle bundles with well-demarcated borders. Finally, endometrial carcinoma is a malignant tumor of the endometrium and is the most common gynecological cancer in resource-rich countries. It usually affects postmenopausal females and presents with abnormal uterine bleeding. The most common subtype is endometrioid carcinoma, which is linked to prolonged exposure to unopposed estrogen. Histology shows confluent endometrial glands without intervening stroma. Now let's talk about benign breast diseases, because fibrocystic changes are the most common in premenopausal females aged 20 to 50 years old, and they present with premenstrual breast pain or lumps, often bilateral and multifocal. Non-proliferative lesions include simple cysts, which are fluid-filled duct dilations with blue domes, and also papillary apocrine change or metaplasia, and stromal fibrosis. The risk of cancer is usually not increased. But proliferative lesions include sclerosing adenosis, which involves acini and stromal fibrosis and is associated with calcifications, and this carries a slight increase in risk for cancer. Epithelial hyperplasia involves cells in the terminal ductal or lobular epithelium, and the risk of carcinoma increases with atypical cells. Now listen carefully, inflammatory processes like fat necrosis are benign, and usually painless, and result from injury to breast tissue. They appear as calcified oil cysts on mammography, and necrotic fat with giant cells on biopsy. Interestingly, up to 50% of patients may not report trauma. Lactational mastitis occurs during breastfeeding and increases the risk of bacterial infection through cracks in the nipple. Staphylococcus aureus is the most common pathogen. You should treat it with antibiotics and continue breastfeeding. Mammary duct ectasia involves dilation of subareolar ducts with inflammation and fibrosis, and it is associated with smoking. It presents with areolar pain, multicolored discharge, inverted nipple, and a periareolar mass. Now, moving on to benign tumors, fibroadenoma is the most common in females under 35 years old, and it presents as a small, well-defined, mobile mass. The tumor is composed of fibrous tissue and glands, and it increases in size and tenderness with increased estrogen, such as during pregnancy or just before menstruation. However, the risk of cancer is usually not increased. On the other hand, intraductal papilloma is a small fibroepithelial tumor within the lactiferous ducts, typically beneath the areola, and it is the most common cause of nipple discharge, which is often unilateral and either serous or bloody. There is a slight increase in cancer risk. Anphyllodes tumor is a large mass of connective tissue and cysts with leaf-like lobulations, and it is most common in the 5th decade, and while most are benign, some may become malignant. Now let's cover gynecomastia, which is breast enlargement in males due to increased estrogen compared with androgen activity. It is physiologic in newborns, pubertal boys, and older males, but it may persist after puberty. Other causes include cirrhosis, hypogonadism such as in Klinefelter syndrome, testicular tumors, and also drugs like spironolactone. Now listen carefully, breast cancer is commonly postmenopausal, and it often presents as a palpable hard mass, most often in the upper outer quadrant. Invasive cancer can become fixed to pectoral muscles, deep fascia, Cooper ligaments, and the overlying skin, leading to nipple retraction or skin dimpling. It usually arises from the terminal duct lobular unit. Amplification or overexpression of estrogen or progesterone receptors, or HER2 which is an EGF receptor, is common. But the triple negative form, which is ER negative, PR negative, and HER2 negative, tends to be more aggressive. Risk factors in females include increasing age, history of atypical hyperplasia, family history of breast cancer, race, with white patients at highest risk and black patients at higher risk for triple-negative breast cancer, and BRCA1 or BRCA2 mutations. Also, increased estrogen exposure, such as nulliparity, postmenopausal obesity due to adipose tissue converts androstenedione to estrone. Other risks include increased total number of menstrual cycles, absence of breastfeeding, later age of first pregnancy, and alcohol intake contribute. In males, BRCA2 mutation and Klinefelter syndrome are important. Remember, Axillary lymph node metastasis is the most important prognostic factor in early-stage disease. Are you ready for more details on breast cancer? Ductal carcinoma in situ fills the ductal lumen, and neoplastic cells can be seen in the duct, often with engorged blood vessels nearby. It arises from ductal atypia and is often seen early as microcalcifications on mammography. This represents early malignancy without basement membrane penetration and usually does not produce a mass. Meanwhile, Paget disease is an extension of underlying cis or invasive breast cancer up the lactiferous ducts and into the contiguous skin of the nipple, presenting as eczematous patches over the nipple and areolar skin. Paget cells are intraepithelial adenocarcinoma cells. As for lobular carcinoma in situ, there is reduced E-cadherin expression, and it produces no mass or calcifications, making it an incidental biopsy finding. It carries an increased risk of cancer in either breast, unlike cis, which typically involves the same breast and quadrant. Now let's continue with invasive carcinomas. Invasive ductal carcinoma presents as a firm, fibrous, rock-hard mass with sharp margins and small glandular duct-like cells in desmoplastic stroma, and it is the most common type of invasive breast cancer. In contrast, invasive lobular carcinoma also shows reduced E-cadherin expression, leading to an orderly row of cells or single-file appearance without duct formation, and it often lacks a desmoplastic response. This type is often bilateral with multiple lesions in the same location. Remember, lobular carcinoma lacks cadherin and forms lines of cells. Inflammatory breast cancer involves dermal lymphatic space invasion and presents with breast pain, warm swollen erythematous skin around exaggerated hair follicles, creating the characteristic peau d'orange appearance. It carries a poor prognosis with only about 50% survival at 5 years. It is often mistaken for mastitis or Paget disease and usually lacks a palpable mass. Now let's switch topics and talk about penile pathology, starting with Peyronie disease, which is an abnormal curvature of the penis due to fibrous plaque within the tunica albuginea. It is associated with repeated minor trauma during intercourse and can cause pain, anxiety, and erectile dysfunction. Treatment includes surgical repair or collagenase injections once the curvature stabilizes. This condition is distinct from penile fracture, which is a rupture of the tunica albuginea due to forced bending. Now listen carefully, ischemic priapism is a painful sustained erection lasting more than 4 hours. It is associated with sickle cell disease, where sickled red blood cells block venous drainage of the corpus cavernosum vascular channels, and also with medications like sildenafil and trazodone. It must be treated immediately with corporal aspiration, intracavernosal phenylephrine, or surgical decompression to prevent ischemia. Continuing with penile pathology, squamous cell carcinoma is seen in the United States but more commonly in Asia, Africa, and South America, and it is the most common type of penile cancer. Precursor in situ lesions include Bowen disease, which appears on the penile shaft as leukoplakia or white plaque, erythroplasia of Queyrat, which is carcinoma in situ of the glands and presents as erythroplakia or red plaque, and Bowenoid papulosis, a carcinoma in situ of unclear malignant potential, presenting as reddish papules. It is associated with uncircumcised males and HPV-16 infection. Are you following me? Cryptorchidism is the failure of descent of one or both testes, leading to impaired spermatogenesis since sperm develop best at temperatures below 37 degrees Celsius, resulting in subfertility. Testosterone levels can be normal since Leydig cells are mostly unaffected by temperature. It is associated with increased risk of germ cell tumors, and prematurity increases the risk of cryptorchidism. Inhibin B levels are reduced, while FSH and LH are increased. Testosterone is reduced in bilateral cases but normal in unilateral. Most cases resolve spontaneously, and if not, orchiopexy should be performed before 2 years of age. And now, let's discuss testicular torsion, which is a rotation of the testicle around the spermatic cord and vascular pedicle. It commonly occurs in males aged 12 to 18 years old and is associated with congenital inadequate fixation of the testis to the tunica vaginalis, resulting in horizontal positioning or a bell clapper deformity. It may occur spontaneously or after trauma, and presents with acute severe pain, high-riding testis, and absent cremasteric reflex, along with a negative Pren sign. Treatment involves surgical correction or orchiopexy within 6 hours, and if surgery is unavailable, manual detorsion may be attempted. If the testis is non-viable, orchiectomy is performed. Orchiopexy should always be bilateral since the contralateral testis is also at risk. Finally, let's cover varicocele, which involves dilated veins in the pampiniform plexus due to increased venous pressure, and it is the most common cause of scrotal enlargement in adult males. It most often occurs on the left side due to increased resistance from left gonadal vein drainage into the left renal vein. If it's on the right side, it may suggest IVC obstruction, such as from renal cell carcinoma invading the right renal vein. Varicocele can cause infertility due to elevated temperature. It is diagnosed by standing clinical exam or Valsalva maneuver, showing distension and a bag of worms feeling on palpation, or by ultrasound, and it does not transilluminate. Treatment involves surgical ligation or embolization if there is pain or infertility. Now let's talk about extragonadal germ cell tumors, which arise in midline locations. In adults, these tumors most commonly appear in the retroperitoneum, mediastinum, pineal, and suprasellar regions. However, in infants and young children, sacrococcygeal teratomas are the most frequent. Moving on to benign scrotal lesions, these are testicular masses that can be transilluminated, which sets them apart from solid testicular tumors. One example is a hydrocele, which refers to the accumulation of serous fluid within the tunica vaginalis. It can be congenital or acquired. Congenital hydroceles, which are communicating, often seen in infants, are caused by incomplete obliteration of the processus vaginalis and usually resolve on their own within 1 year. In contrast, acquired hydroceles non-communicating result from infection, trauma, or tumor and are termed hematoceles if the fluid is bloody. Next, we'll discuss spermatocele, which is a cyst caused by dilated epididymal duct or reedy testis. It typically presents as a paratesticular, fluctuant nodule that can be felt during palpation. Now shifting to testicular tumors, germ cell tumors make up approximately 95% of all testicular tumors. They arise from germ cells that produce sperm and most frequently occur in young males. Risk factors include cryptorchidism and Klinefelter syndrome. These tumors often present as mixed germ cell tumors and do not transilluminate. Biopsy is usually avoided to prevent seeding the scrotum, so radical orchiectomy is the preferred treatment. On the other hand, sex cord stromal tumors, which develop from embryonic sex cord derivatives such as Sertoli and Leydig cells or theca and granulosa cells, account for 5% of testicular tumors and are mostly benign. Now listen carefully, among germ cell tumors, seminomas are malignant and present as painless, homogeneous testicular enlargement. They are the most common testicular tumors and are analogous to ovarian dysgerminomas. Seminomas do not occur in infancy. Histologically, they show large cells and lobules with watery cytoplasm and a fried egg appearance, and they are associated with increased placental alkaline phosphatase. They are highly radiosensitive, metastasize late, and have an excellent prognosis. Embryonal carcinoma, also malignant, presents as a painful, hemorrhagic mass with necrosis. Pure embryonal carcinoma is rare and often occurs as part of a mixed tumor. It may present with metastases and is associated with increased HCG and normal AFP when pure, but increased AFP when mixed. It has a worse prognosis than seminoma. Are you following me? Let's continue with teratomas, which, when mature, may be malignant in adult males, although they are benign in children and in females. The yolk sac tumor, also known as an endodermal sinus tumor, is malignant and aggressive. It appears yellow and mucinous and is the male counterpart of the ovarian yolk sac tumor. It features Schiller-Duval bodies that resemble primitive glomeruli, and elevated AFP levels are a highly characteristic finding. This tumor is the most common testicular tumor in children under 3 years of age. Another important tumor is choriocarcinoma, which is malignant and composed of disordered syncytiotrophoblastic and cytotrophoblastic elements. It metastasizes hematogenously to the lungs and brain and is associated with increased hCG levels. This elevation may cause gynecomastia and symptoms of hyperthyroidism, as hCG and TSH share an identical alpha subunit and a similar beta subunit, which determines their hormonal function. Now let's turn our attention to non-germ cell tumors, starting with Leydig cell tumors, which are mostly benign. These tumors have a golden-brown appearance and contain Reinke crystals, which are eosinophilic cytoplasmic inclusions. They produce androgens or estrogens, which can lead to precocious puberty or gynecomastia. Sertoli cell tumors, also known as androblastomas, arise from the sex cord stroma and are mostly benign as well. Another key malignancy is primary testicular lymphoma, which is aggressive and typically presents as diffuse large B-cell lymphoma. It is often bilateral and is the most common testicular cancer in males over 60 years old. Now listen carefully as we review hormone levels in germ cell tumors. In seminomas, PLAP is increased, while AFP is not elevated, and beta-HCG can be normal or increased. Yolk sac tumors show markedly elevated AFP levels, but PLAP and beta-HCG are typically not elevated. In choriocarcinomas, beta-HCG is significantly elevated, while PLAP and AFP are not. Teratomas show variable AFP and normal beta-HCG, and PLAP is also normal levels. Embryonal carcinomas also show variable increase AFP, high beta-HCG and normal PLAP. And now, let's discuss epididymitis and orchitis, beginning with their most common causes. In young males, the culprits are usually Chlamydia trachomatis and Neisseria gonorrhoeae, while in older males, Escherichia coli and Pseudomonas are more often implicated, often linked to urinary tract infections and benign prostatic hyperplasia. Autoimmune causes may also occur, such as granulomas involving the seminiferous tubules. Epididymitis presents with localized pain and tenderness over the posterior testis, and it features a positive Pren sign, which means that pain is relieved with scrotal elevation. If it progresses, the condition may extend to involve the testis. On the other hand, orchitis refers to inflammation of the testis itself and presents with testicular pain and swelling. Mumps orchitis, in particular, increases the risk of infertility and is rare in males under the age of 10. Benign prostatic hyperplasia is common in males over the age of 50, and it is characterized by a smooth, elastic, firm nodular enlargement of the transition zone, which results from hyperplasia rather than hypertrophy, and this enlargement compresses the urethra into a vertical slit. It is important to note that this condition is not premalignant. Patients often present with increased frequency of urination, nocturia, difficulty starting and stopping the urine stream, and dysuria. This can lead to distension and hypertrophy of the bladder, hydronephrosis, and urinary tract infections. Total PSA levels are typically elevated, while the fraction of free PSA is decreased. PSA itself is made by the prostatic epithelium and is stimulated by androgens. Now regarding treatment options, they include alpha-1 antagonists like terazosin and tamsulosin, which cause relaxation of smooth muscle, 5-alpha reductase inhibitors such as finasteride, PDE5 inhibitors like tadalafil, and surgical resection including TURP and ablation. Now let's talk about prostatitis, which is characterized by dysuria, frequency, urgency, and low back pain, and the prostate is usually warm, tender, and enlarged. In acute bacterial prostatitis, E. coli is the most common cause in older males, while in younger males, C. trachomatis and gonorrhoeae should be considered. Chronic prostatitis may be bacterial or non-bacterial, which can result from previous infection, nerve problems, or chemical irritation. Now listen carefully, because prostatic adenocarcinoma is a common malignancy in males over 50 years of age, and it most often arises from the posterior lobe or peripheral zone of the prostate gland. Diagnosis is frequently based on elevated PSA levels followed by needle core biopsies that are transrectal and ultrasound guided. Histologically, the tumor is graded using the Gleason system, which assesses glandular architecture and correlates closely with metastatic potential. Tumor markers like prostatic acid phosphatase and PSA are useful, and typically there is an increase in total PSA and a reduction in the fraction of free PSA. In advanced stages, osteoblastic metastases to the bone may develop, often causing lower back pain and increased serum ALP and PSA levels. Metastasis to the spine occurs frequently through the Batson or vertebral venous plexus. The regulation of sex hormone synthesis begins at the level of the hypothalamus, which releases GnRH, or gonadotropin-releasing hormone, to stimulate the anterior pituitary. The anterior pituitary then secretes LH and FSH, which act on the ovaries and testes. Certain drugs act at this early level, including combined hormonal contraceptives, which inhibit the hypothalamus and anterior pituitary, thereby suppressing GnRH, LH, and FSH secretion. Clomiphene, however, stimulates GnRH release by blocking estrogen feedback, while degarelix directly inhibits GnRH receptors. Goserelin and leuprolide can act as either agonists or antagonists at GnRH receptors, depending on dosing patterns, and both combined hormonal contraceptives and danazol also inhibit the anterior pituitary. Now let's talk about the ovaries. LH and FSH stimulate the production of androgens and estrogens. Within the ovarian steroidogenesis pathway, CYP450C17 converts precursors into androstenedione and testosterone. This step is inhibited by ketoconazole and danazol. From there, the enzyme aromatase transforms androgens like androstenedione and testosterone into estrogens, such as estrone, estriol, and estradiol. Aromatase is blocked by anastrozole, letrozole, and exemestane. These estrogens then bind to estrogen receptors, which regulate gene expression in estrogen-responsive tissues. Tamoxifen and raloxifene modulate the estrogen receptor, acting as selective estrogen receptor modulators with both agonist and antagonist effects, depending on the tissue. Are you following me? Now let's shift to the testis, where LH stimulates testosterone production, and FSH supports spermatogenesis. Testosterone can act directly, or it can be converted by the enzyme 5-alpha reductase into dihydrotestosterone, or DHT, which has a stronger affinity for the androgen receptor. This 5-alpha reductase enzyme is specifically inhibited by finasteride. Once testosterone or DHT binds to the androgen receptor, they form a complex that regulates gene expression in androgen-responsive cells. However, drugs like flutamide, bicalutamide, and spironolactone can block this androgen receptor, preventing activation. And before testosterone is even formed, drugs like abiraterone, ketoconazole, and spironolactone can inhibit steroid synthesis at earlier steps, reducing the overall production of testosterone. Now let's explore gonadotropin-releasing hormone analogues such as leuprolide, goserelin, neferilin, and histrelin, which act as GnRH agonists when administered in a pulsatile fashion. However, when used continuously, they initially act as GnRH agonists, causing a tumor flare, but eventually function as antagonists by downregulating GnRH receptors in the pituitary, which leads to reduced FSH and LH, decreased estrogen in females, and decreased testosterone in males. These analogues can be used instead of GnRH and are clinically indicated for uterine fibroids, endometriosis, precocious puberty, prostate cancer, and infertility, with the pulsatile regimen used for pregnancy and continuous for cancer. Adverse effects include hypogonadism, reduced libido, erectile dysfunction, nausea, and vomiting. Next, let's discuss degarelix, which is a GnRH antagonist that does not cause the initial flare effect seen with agonists. It is used for prostate cancer, and its adverse effects include hot flashes and liver toxicity. Now moving on to ethinyl estradiol, which binds estrogen receptors and is used to treat hypogonadism or ovarian failure, serves as contraception when combined with progestins, and is part of hormone replacement therapy in postmenopausal females, though it is advised to use it for less than 5 years to lower the risk of side effects. Adverse effects include increased risk of endometrial cancer when given without progesterone, postmenopausal bleeding, hepatic adenoma, breast tenderness, and elevated risk of thromboembolic events. It is contraindicated in people over 35 who smoke tobacco, and in patients with a high risk of cardiovascular disease, including those with venous thromboembolism, coronary artery disease, stroke, migraines especially with aura, breast cancer, or liver disease. Now let's go over selective estrogen receptor modulators, beginning with clomiphene, which is an antagonist at estrogen receptors in the hypothalamus, and it prevents the normal feedback inhibition, thereby increasing the release of LH and FSH from the pituitary, which in turn stimulates ovulation. It is used to treat infertility due to anovulation, such as in PCOS, and may cause hot flashes, ovarian enlargement, multiple simultaneous pregnancies, and visual disturbances. Tamoxifen acts as an antagonist at the breast, a partial agonist at the uterus and bone, and it can cause hot flashes, an increased risk of thromboembolic events especially in smokers, and may lead to endometrial hyperplasia or cancer. It is used to treat and prevent recurrence of ER/PR-positive breast cancer and to prevent gynecomastia in patients undergoing prostate cancer therapy. Finally, raloxifene is an antagonist at both the breast and uterus, but an agonist at bone, and while it causes hot flashes and increases the risk of thromboembolic events, it does not increase the risk of endometrial cancer unlike tamoxifen, which is why you can relax with raloxifene. It is primarily used to treat postmenopausal osteoporosis. Aromatase inhibitors like anastrozole, letrozole, and exemestane work by inhibiting the peripheral conversion of androgens to estrogen. These are used primarily in ER-positive breast cancer in postmenopausal females, and letrozole can also be used to treat infertility caused by anovulation, such as in PCOS. Moving on, progestins including levonorgestrel, medroxyprogesterone, etonogestrel, norethindrone, and migestrol, bind to progesterone receptors, reduce the growth and increase the vascularization of the endometrium, and thicken cervical mucus. These are used for contraception through various forms like pills, intrauterine devices, implants, or depot injections, and they're also used in treating endometrial cancer and abnormal uterine bleeding. A progestin challenge test, where bleeding occurs upon withdrawal, helps exclude structural defects like Asherman syndrome and chronic anovulation without estrogen. Now let's talk about antiprogestins such as mifepristone and ulipristal, which act as competitive inhibitors of progestins at progesterone receptors. Mifepristone is used for pregnancy termination in combination with misoprostol, while ulipristal serves as emergency contraception. Moving into contraception methods, hormonal options that combine estrogen with progestins, or use progestin alone, prevent ovulation by decreasing GnRH, leading to reduced LH and FSH, which then prevents the estrogen surge and the LH surge. Progestins also thicken cervical mucus to reduce sperm entry and thin the endometrium, making it less suitable for implantation. These forms include oral contraceptive pills, transdermal patches, and vaginal rings. Next, we discuss intrauterine devices, where the copper IUD, which is hormone-free, causes a local inflammatory reaction that is toxic to sperm and ova, preventing both fertilization and implantation. However, IUDs can increase the risk of abnormal uterine bleeding, and their insertion is contraindicated in patients with active STIs or heavy menstrual bleeding. On the other hand, the progesterone IUD works similarly to progestins. And when we consider surgical contraception, vasectomy in males and tubal ligation in females are used to ensure there's no sperm in the ejaculate or that sperm cannot reach the ovum, and both methods are generally irreversible. Now shifting gears to tocolytics, these are medications that relax the uterus, and they include terbutaline with beta-2 agonist action, indomethacin which is an NSAID, and nifedipine which is a calcium channel blocker. These drugs are used to reduce contraction frequency in preterm labor and to allow time for administering glucocorticoids to help fetal lung maturity or to arrange transfer to a medical center with proper obstetric care. Just remember this, keep the baby in the TN, terbutaline, indomethacin, nifedipine. Then we have danazol, a synthetic androgen that acts as a partial agonist at androgen receptors, used in conditions like endometriosis and hereditary angioedema. However, it may cause weight gain, edema, acne, hirsutism, masculinization, lowered HDL, hepatotoxicity, and idiopathic intracranial hypertension. Now let's continue with testosterone and methyltestosterone, which are agonists at androgen receptors, used to treat hypogonadism and to promote the development of secondary sex characteristics. Yet they can lead to virilization in females, testicular atrophy in males, premature closure of epiphyseal plates, acne, increased erythrocytosis, and alterations in lipid profiles with higher LDL and HDL. As for antiandrogens, abiraterone inhibits 17-alpha-hydroxylase and 17,20-lyase to reduce steroid synthesis and is used in prostate cancer, but may cause hypertension and hypokalemia due to increased mineralocorticoids. Finasteride, a 5-alpha-reductase inhibitor, blocks conversion of testosterone to DHT, and is used for BPH and androgenetic alopecia, though it may cause gynecomastia and sexual dysfunction. And now, we'll go on to flutamide and bicalutamide, which are nonsteroidal competitive inhibitors at androgen receptors, and they reduce steroid binding in prostate cancer treatment, but like finasteride, can cause gynecomastia and sexual dysfunction. Ketoconazole, another antiandrogen, also inhibits 17-alpha-hydroxylase and 17,20-lyase, and is used in prostate cancer, potentially causing gynecomastia. Spironolactone blocks androgen receptors and the same two enzymes, and is used in PCOS, but can lead to amenorrhea. Then there's tamsulosin, which is a selective alpha-1 antagonist targeting alpha-1A/D receptors in the prostate rather than vascular alpha-1B receptors, thereby reducing smooth muscle tone and increasing urine flow, which is useful in BPH treatment. Finally, minoxidil, a direct arteriolar vasodilator, is used in treating androgenetic alopecia and severe refractory hypertension.